Here from day one. We are the ones that carry out the order. Ya estamos live? And, okay, we're live. Hi guys, ¿a qué cámara le miro?
Ahí está.
¿Esa es la 1 y la 2?
Sí.
1, 2. 1 and 2, only 1. Okay, so guys, we're already live. Nico Lopez coming to you live. Finally, we're so blessed to be here from our wound healing and our amputation prevention conference. This is our third one. We kept postponing because of COVID. We already had a plan on the 20. We didn't do 20, we did 18, 19, then we did 20, then we did 21. And then 22, I was just recovering from my PTSD from almost dying in 2020 from COVID. There were a lot of changes, and we just didn't know if we were up to do it. So we were focused on refilling our own cup before we did another conference. And we were focused on seeing our patients, right? We had a lot of wound patients that were trying to get in to see us that we needed to get caught up seeing. So that's what we did. And finally, I apologize for all the vendors that were not able to get a booth. I literally started promoting the conference 4 weeks ago because I said if I do not, I put the date a year ago. I made an event. Some of y'all already put on the event back then. But stay right here with me, my friend. Dr. Michael just walked in. He's going to sit right here with me because he's a VIP. Everybody's a VIP. Love you, sweetheart. We're already live on our channels. And so here we are again doing this. So those of you that know me know that I have ADD. So I just lost my train of thought. So I will circle back. So we were seeing the patients. And so now here we are. So 4 weeks ago, I went ahead and said, okay, if I don't do the conference now, I'm not going to do the conference against this year. I said, I don't care who shows up. If it's just my fiance, my team, and I, my brother, a couple people that show up. My brother's Lopez. He's a PA with cardiology. I'm very proud of him. He's Dr. Lopez. And I said, I'll have the videos. I'll upload them to the channel, and that's that. Because we get a lot of our patients and our nurses and our colleagues that are networking from our Facebook. It's an amazing way to network. So we have a lot of people here. I can't believe how many of you guys here are here so early. Now I'm getting kind of worried because I have like 40 RSVPs that are texting me. I'm on my way, and I'm thinking we're going to pull another table up. But that's okay. We have plenty of food. So guys, what is the conference about? This conference is about amputation, prevention, and wound healing. We are not here to teach you how to do wound care. We as nurses are trained to do wound care from day one. There are a lot of, is this better? Because I don't want to be echoing. Señor, ¿así un poquito mejor para el eco o se oye bien el sonido?
Un poquito arriba.
¿Un poquito para arriba? Okay. We want you to learn how to heal the patient out. A lot of you that are here, I've had patients with, and we have healed out patients together. There's a lot of different modalities to do it, and the concepts are very, very simple. I always get about 10 speakers, and most of them commit, and then 5 fly out, get sick, something happens, so I always have backups. And this year, all of my speakers came through, and I'm texting saying, why are you going to come speak? You're supposed to cancel, because then now I don't have slots for me to speak. I'm just kidding. But I think everybody's so hungry to just network and to be back, our normal lives that nobody wants to come to school. I'm joking, I'm very happy that they're all going to be here. So we're going to cover different topics. We're going to do a little walkthrough, and we're going to talk to, there's people that don't want to talk or can't talk, but we're going to say hi to our vendors. And then we're going to get started. We're going to go from, guys, it's hot. Tell the guy to bring it down to 60 or something. These people are defending themselves. And when we get more people, we have a lot of lighting. And then we have this, and we're going to. So we're gonna speak about different topics that are required in order for you to heal. For example, peripheral vascular disease. That applies to lower extremity. Does it apply to upper extremity wounds? Yes. This is an extreme. I've had patients that lose an arm because nobody did a vascular assessment. This is where us as patient advocates and our show, we just started our social media show yesterday. The first thing I talked about was wound care because I want the entire world to see those YouTube shows, Facebook shows. We want patients, family members, husbands, wives, children to see and say, oh, that's how it's supposed to happen? My mom has a foot wound and she's never had a vascular assessment. I'm going to ask my doctor to send me to a cardio, or I'm going to be empowered and I'm going to go to the cardio. Main thing we want to impress upon everyone. Both my friend Kyle, that's your booth, my friend, you know it is. And the first thing we want to impress upon everybody is look for help. We are in a subservient culture in the valley. I'm seeing all these people that are honoring me with their presence, and I just can't get out of it, so I'm going to be waiting. Empower you guys as nurses, as nurse practitioners, as doctors to be okay saying, this patient's not getting better because they're still with their doctor for 40 years, slapping Silvadene. I'm so sorry. I am a patient advocate. I am a nurse above all. And we take very seriously the advocacy part of what we do. Matter of fact, I get in trouble a lot because I advocate for everyone, not just patients. When I'm in the community and I see a child that his voice is not heard and I'm concerned about the school, I speak to the superintendent and help the parent file a report, and that sometimes can get you in trouble. But the child appreciates it. That's what advocacy is about. So if you as a patient, those of you watching live, if you as a child of a patient, as a nurse practitioner, as a doctor, are treating a patient, if you're on that clinical end, they're not getting better, seek a second opinion from an expert in that field. I have learned, and I'm very, very blessed to be humbled enough to say, I'm not doing PAPs anymore in the clinic, right? Dee's here. She's helped me build the clinic from when we had no patients and we go swimming. Like, we don't have any work, let's go to the gym, and we'd swim for hours, and that's what we would do for the day because we didn't have any patients. That's over 10 years ago. Now we want to go swimming and we can't even eat, praise be to God. So you have to be okay saying, we used to do PAPs. And then I said, I'm not doing PAPs. You have to go in there and relax the area, and we're like waiting so the lady's not screaming. And they let me send these to the gyms. I'm a primary care family nurse practitioner, but I don't want to be doing this. Thank God I don't have to do it. I don't do PEs. I'm family practice board certified. I'm also adult geriatric acute care nurse practitioner board certified. And then I'm a certified skin specialist and a certified skin and wound specialist. So I have those two. I love sport. Have you guys ever heard, and I'm going to have to go back and forth with English and Spanish because we do English and Spanish shows and we have a lot of Spanish speaking people. Zapatero a su zapato. Have you ever heard that? Let the shoemaker make the shoe. So I started learning that also, el que mucho abarca, poco aprieta. He that tries to gather too much squeezes little. I don't know how to translate it better than that. So I said, okay, I am now 46. I think I need to channel my energy so I can last another 40 years. Okay? So we've been focusing. I can do pediatrics. And I have my friends sometimes go, can you please take over? I don't want to do your child's wellness assessments and all of the anticipatory guidance and all the vaccines. I can't stand vaccines. I like adult vaccines. So also we do a lot of geriatrics in the clinic, Lopez Human Clinic. I don't want your children coming. They're very infectious, and they're going to infect my geriatric patients, my wound patients. Remember, wound patients are already immunocompromised. They have a hole in their body. You're going to see that as I speak, I'm going to give a lot of pearls. Just because there's too much to say. And since I have all my speakers confirmed, I don't know how much I'm going to be able to get in. But I am doing the show, and we are putting up the slides of everything that we're covering. So all of those things are very, very important, that patients with wounds are not exposed to sick people. A lot of children, we want the children on it, but if the child is sick, the wound's not going to heal. And be empowered to refer out. Patient comes in, I do my full workup. You're still having abdominal issues, I have to send you to your GI so you can get an EGD, colonoscopy, it's a time, because that's his specialty, right? I referred my wounds to my colleagues. I need hyperbarics. I don't have hyperbarics. I'm doing this, something's happening. What is it? Is it here? I hear a little E. No? It's just me, right here. Okay, a little bit, right? So, refer out. HBO, call my friend, hey, I have a patient that may benefit. I'm not seeing progress, it's been 2 months. I take it you guys have to, after 4 weeks of wounds not healing, that is a non-healing wound. You gotta refer out. That's what textbook. You gotta refer out, guys, for the good of the patient. Stop slapping Silvadine, wet to dry, betadine, on everything. And the main concept, if you guys get nothing from me at all today, I have one concept to share with you, maybe two. One, be a patient advocate. If you're not healing, go somewhere else. 4 weeks you're not healing, go somewhere else. Now, you may not be fully healed, because I have patients coming, I've had this for 9 years. Okay, 2 weeks later, when am I going to heal? Pardon me, I just got the case. You had it for 9 years, you have so many comorbidities. I don't know when you're going to heal, but are you healing? Are you progressively getting better? I always ask patients, are you better, the same, or worse? That's it. Better, same, worse. No, I'm better. Okay, you're better. Let's give us some time. Every week we should feel a little better. We should get a little better. And that goes with everything. All primary care, anything you're treating, we should be getting a little bit better. If the patients are compliant. Seek help. Second opinion, third opinion, fourth opinion. I don't care. Give each provider 4 weeks. If they have bad bedside manner, give them 1 visit and don't go back. Bedside manner matters. Bedside manner matters. Positivity matters. Being hopeful to your patient matters. Having faith that the patient's going to heal. And I have to, a little disclaimer, I don't heal the wounds. God heals the wounds in our clinic. We are a good team and we do it as a team, but God heals the wounds in my clinic. I'm not that, proud that I feel like I heal the wounds in my clinic. But we put in the work. And the second thing is, 1, advocacy. 2, if the wound is wet, do you wet it? Why is this hard to understand, my team members? If the wound is wet, do you wet it? No. Colleagues and friends, stop wetting wet wounds. So is an ointment wet? Yes. Is Silvadine wet? What is Silvadine for? What is Silvadine for? Why is it on all the wounds in the valley? Right? Why are we giving everybody oral antibiotics? You haven't even you don't give oral antibiotics for chronic wounds. Why are we doing more washes with Ibicans? Topical. Why don't we do a natural punch biopsy and send out for culture? That's the proper way to culture. Stop swabbing the wounds. Right? And if the wound is dry, do you dry it? What do you do to the dry wound? You wet it. That's it. Whenever you're out there practicing, if you see a wet wound, don't be like, I should put Neosporin on this. No, it's that simple, guys. So that is the one thing I teach everyone. What time is it? Keep me on time. At 9, my brother's going to start. Thank you. I speak real fast because I want to say a lot of stuff. And now that we're doing the show, I'm like, a 30-minute show, I can say everything I want to say in 10 minutes. So I have to. But not today. So, if the wound is wet, how do you dry a wound? Anybody can share? How do you dry a wound? There's dressings, alginate dressings that are available that you can put on the wound. It'll suck up this look, right? Depending on where the wound is, you can elevate. You need to address the edema. That's part of my slides. If there's any edema. Does everybody get Lasix for swollen legs? Please no. Please no. Ismael, does everybody get Lasix for swollen legs, sir? No. Why not? There's so many reasons. Está platicando con el amigo. Treatment is not always Lasix. All right? Treatment is not always Lasix. Whenever I'm in these conferences, I always say hi to people as they walk in, and it's really good for the show and everything. But I want to tell you guys a story about my friend Kyle this morning. Just because, he's our main guy today. So we want to applaud and thank Kyle for coming all the way from, was it Pennsylvania, my friend? Tennessee. Guy flew in from Tennessee to be here with us. Thank you, Kyle. Only problem is Kyle had his phone off, so he just walked down here and is barely saying hi to me right now. But he's still on time. Kyle, we just started, Kyle. Thank you, brother. So we're going to tell you a little bit more about his product in a minute. So if the wound is wet, if the wound is wet, if the wound is wet, how do you dry it? Product. What else? Elevate. Take care of the edema. Compression. Do you apply compression on a patient on the legs without ruling out a DVT? Why? We can't. Please don't do it. Do you over-compress? Do not over-compress. You're going to cause more wounds. Very basic. These are very common sense things that we think about. I've been told I order too many tests on my patients because you know how when we were taught that it's unnecessary to order that test. Well, hold on. You don't know what I know. I respect everybody's opinion. But we all come to the table with our knowledge or lack thereof. Yes? Yes. You don't know what I know. You don't know what I've read. You don't have my board certifications. You haven't touched the wounds I've touched or taken care of the patients in the hospital that I've taken care of. So at the beginning, when I was doing the debriefing, one case would take me 3 hours in the hospital. You can vouch for that. And I have some people here that have been part of my history, and it makes me want to cry because it means a lot to me that you're here today. But if you want to do what's right for the patient, you're going to take your time. And then I figured out, I'm not on hourly salary. I get paid per visit, and I'm doing 3 hours on these patients to do one debridement. Maybe I should debride less wounds per visit because I'm tired. And by the 3rd hour, I still needed to do my usual 20-page notes that I would type up in the hospital charts because I had 22 wounds. And April liked to order 5 different wound cares because they were different wounds. So I would get called and, can I just put Betadine on all of these? No, you can't. That's why these patients don't heal. I took my time to write you 5 different orders for 22 different wounds. I sized the wounds. I debrided the wounds. Some didn't need debridement. Some of them need Santos. Some of them need Hydrofera Blue. Do I have to use Hydrofera Blue? Yeah, you have to use Hydrofera Blue, my friend. It's a wonderful product. I can't afford the Santo. We try to find ways to help patients get it. It's expensive. Okay, you can't afford it. We try something else. Do I have to use this powder? Well, I mean, I wrote it. I don't know what to tell you. The wound is wet. You need to dry it. There's so many powders, guys. So many powders out there, you know, that you can use. When a patient can't afford it, we find a way to help them. So if the wound is wet, dry it. If the wound is dry, wet it. If you need to compress, lower extremity, rule out your DVTs. A little pearl. You guys know about the vendor with the real big machines for compression, the pneumatic compression machine. It's very expensive. Sorry, guys. We've had them at our conferences before. I don't even reach out because they're so expensive and most insurances don't cover. And then there's all these prior authorizations. Sorry, the vendor, I'm not saying the name, but there's all these prior authorizations. So I'm like embarrassed to even bring them to a conference, have them pay a booth. If I'm never going to send one patient their way because it's not worth it and I don't want the patient to pay a ton of money, then the patient's like, they want me to pay $800 copay. I found those things, sorry, I know you're going to tell me they're not the same. I found those things on Amazon. One of my patients and the nurses in the field and my colleagues are my best, I love to see you, are the best people that teach me, right? So I have a patient that said, look what I found on Amazon, look, my legs are all better because we would compress him. And he hated it. He hated the vendas. But when you compress, how do you apply the compression? From the foot to the below the knee, right? Foot to below the knee, right? So then this patient hated it because he was robotito, chubby, and it bothered him. So he goes, look, Nita, I found this machine on Amazon. Look at my legs, they're all better. If you turn it on, and I'm like, oh my gosh, $299? $299 and I could change people's lives. $299. Wow, amazing. So I started telling all my patients, look, when we get you healed or we get you almost healed, we're going to roll out a DVT and you're going to get this machine. Right? If they can't afford it, we find a way to get it to them. Very important. Yes, Dr. Michael? Is it a game changer, Dr. Michael? Absolutely. Is it simple to do? Yes. But you have to look for another option for the patient. I love all my years of nursing. Where have I worked? Those of you that know me in the community, I have worked everywhere. I started as a floor nurse. I'm a float pool nurse. I'm in ER. I'm very proud. Those of us that are acute care, we kind of walk a little bit like this. I'm an ER night nurse. I smoked and drank coffee for a long time. I loved it. Don't smoke, kids. Don't smoke. But I did it. If you're a night shift nurse, don't lie. If you're not, you never did that, you're not cool like us. We acute care people are a little bit different. Love it. I'm a trauma nurse. Then I went to NP, so I worked everywhere. The only thing I've never done, I don't like to labor women. I don't like to labor women. Hats off to the L&D nurses, I like to do that. So I've done it all. And all those nights doing those chart checks, nobody told me that I didn't have to go back to the date of admission. So those of you that have worked night shift, I would just see the nurse, they're like, do your chart checks. I'm like, oh my gosh. And my first day on shift, I flipped the chart all the way over back when we had paper charts, which I miss and love. I don't care what people say. I love and miss paper charts. It's the only true thing you have. A piece of paper and a pen. Electronic charts disappear. So then I would flip it over to the front, to the very admission date, and I look at the admission orders, all the labs, all the orders. Thank you, because I melt when I speak. It's a sign of high intelligence. If you melt when you speak, it's a sign of high intelligence. So, and this is so freaking hard. So I would flip it to the front of the chart, and I'd make sure every order was done. Oh, the X-ray, was the X-ray there? Yes. And then by the time I finished my shift, I was so tired. I was always running behind. Remember, these were the days when on the floor on the telly for Atleti Regional with Robert Lopez and Andy and Lynn. Those people are still there. Robert's watching me from heaven. My good friend and mentor. Remember Robert? Let's clap for Robert Lopez. May he rest in peace. House supervisor, this is Robert. Can you come start a line for me? Ontase, bro. I'm over here with the PDs. Oh, I would. Right? Giving me chills. So I was there doing my chart checks, and then finally, about 2 years later, they said, what are you doing? I said, well, my chart checks, I don't know how you guys finished it. Hey, bro, you don't have to go to the very beginning of the chart. It's 24-hour chart check. 24 hours. I'm like, so just for today? I said, well, all that reading, all that stuff actually helped me a lot. Why did I say that story? My ADD sometimes doesn't get the best of me. Because you don't know what I know. You don't know what I know, and we have to respect that. So when I come to you and say, this is what's working, and you say, I'm not going to do that, you don't know what I know. I already did this with 1,000 patients. So we have to be open. I rule out a DVT before I compress the patient. Why? If those were your legs, would you want me to rule out a DVT? You better rule out a DVT on me. If I don't know any better, you as a clinician should know better than me. Nothing's going to happen. Then the patient's using the compression at home, and he has a PE, or he has a... I had a kid with a D-dimer super high. A kid. What was the chief complaint in primary care? After 2 years after I got my vaccine, I've been short of breath. I thought, he's probably making it up. You cannot tell patients they're making it up. You work up your patient. Bless you. I sent him over for labs, included the D-dimer. Kid comes back. Positive D-dimer. Oh, he might have a PE all this time. He's still alive because he's young. Send him straight to the ER. I hope he doesn't have a PE. But he has the symptoms and a positive D-dimer. He needs a workup. You don't know what I know. Maybe you didn't know that you had to. So my modalities are very, very thorough. Listen to the patient, holistic patient, look at the whole patient, work up the patient. If it's not working, change it. Follow up, see the patient every week. There's a lot more to it than that. You see the patient, you assess, you modify, you treat. See the patient, you assess, modify, you treat. There are some patients that will not heal. Sorry. I'm not God. But I have found 99% of the times something's off there. So hi, thank you so much for coming. Make yourself at home. What's off? I've seen family members mess with wounds when thank you. I always say Mexican, because I'm Mexican, I can say it. Don't tell me I'm racist. And I can tell my daughters to suck it up and be tough girls. Don't tell me I'm sexist, because you have to be a strong Latina. So I give an order, and I come back, and I look at the patient. I'm like, you've been walking on the foot. You've been not using the powder. And you're like, how do you know, miss? How do you know? Because I've been doing this for 26 years, and I know how the wound should look. You should be halfway healed by now. And then as soon as they come in, don't let your abuelita, your sister, your friend come and bring you some remedios from next door, where you're going to be putting a little spit on it with Vicks. I'm not kidding. That's not the only thing they put. They like to bring a lot of meds from Mexico. Mexico is a wonderful place, but they also have stuff like that Orly, Trio, whatever, with ajo something. It's all steroids. They have meds. They're not overseen like us. So it was all steroids. My patients were on steroids for 6 months, 1 year, and they were all swollen, and they would have severe body aches. It was really bad for them. They were on steroids. They didn't need the steroids. So there's a lot of meds. Remember Panafil? When we used to use Panafil? There we called it. What happened with Panafil? I'm dating myself. I'm 46. I've been doing this 26 years. Right? Panafil ate your skin. It would eat all your skin up. We didn't know it was doing that until, I guess, a couple people sued and they took Panafil off the market. We don't have those people who are seeing things from next door, and we're right next door, so that's why a lot of our patients are not healed. And then you have your non-compliance. And always ask, is non-compliance non-compliance? Or lack of knowledge? Or lack of funds? Lack of transport? Lack of love? Lack of family support? That's why I love home health. You need a nurse in the home to coordinate the healing for the patient. Right? Why? They don't heal. They don't listen. They forget. They sit on the wound all day. They don't understand. Sometimes I'm talking to patients, guys, we're all walking that way. Come to find out I have to lose 40 pounds. Are you kidding me? I have earned my 175, 46-year-old pounds, but my knee keeps getting injured. And my doctor's here, so he's going to be like, wait till I grab you. I have to lose, do I have to be lean to be able to withstand my joints? My joints cannot carry that much weight because I've already injured it twice. So I'm like, I have to be skinny. I already did it. I'm very comfortable. My knee keeps getting re-injured because when I try to go do cardio with 175 pounds, so if I weigh 130, like I used to, I'm going to be off my BP med, and I'm going to be able to work out better. There's nothing I can do. Obesity is rampant. That's another reason why patients don't heal. But my point is, we're all going that way. My grandma tells me, donde te vi, and this always makes me want to cry because she has Alzheimer's now, and she still remembers us, but a lot of people she doesn't remember. And they used to have a saying, donde te veo me vi, y donde me ves te verás. What does that mean in English? Where I see you, I saw myself. And where you see me, you'll see yourself. And may we be one of the blessed ones that are able to get there. I'm going to draw out a puzzle. I don't want to get there with Alzheimer's. In the name of Jesus. I'm going to get there with my brain. I'm going to practice. I always tell my babe, this wonderful man here is my fiance. And I'm going to marry him October 28th. And my baby, he's my king and my rock. But he's a little bit younger than me. Just a tad bit. Right, brother? Just a little bit. But I'm going to say this. If I was a 46-year-old man, everybody would be fist bumping me right now. Am I wrong? Girls, take notes. Take notes. I have to modify my behavior, my food, my habits. Kyle and I were talking about this last night. Kyle, what did we eat, Kyle?
Sushi.
Sushi, sashimi. Without the rice. We just ate raw fish. A nice Wagyu steak. American Wagyu, not Japanese. With greens. What I drink, Kyle? I drank water. And I drank ginger ale. You know why? Because if I have a drink, I'm going to have palpitations all morning. And if I eat some rice, man, I'm going to wake up with stomach pain. And because I'm 46, so you have to modify. Patience, now I find myself, thank God I'm still 46, I don't need readers. I can't believe it. But I tell my babe, when I used to kiss you before, I saw you clear all the way over here, so now I'm starting to see you clear only up to here, and it makes me want to cry. I thank God I got with him when I could see him clear because he has beautiful eyes. But the point is your body changing? Your body's changing. Can your patient hear you? I said all that to bring that home. Can your patient hear you? How fast do you speak to your patient? I'm like, we're going to do this. Okay, vamos a poner esto, we're going to do this, I'm going to bring you this. And I walk out and the patient's like, they used to call me the tornado when I was 21 and became an RN. I was super fast. I had so much energy. I slept 15 minutes a day. I did that for 5 years, 15 minutes to 1 hour. That's how I was able to build my first companies because my brother can vouch. We come from nothing. My mom was a single mother of 4. We were born in McAllen, lived in Reynosa. English is our second language. My first language was Spanish, but we were U.S. citizens, so mom wanted us to go to school. And my brother became a PA. Ismael Lopez, he's over there. And my mom is now an RN. And I'm an NP. What time is it? It's 9? It's 9 already? 9. So we're going to speak. So, with all that said, when your patient, after you've given your instructions, if you are the provider, have your people follow behind you and say, don't worry, I'm going to write it all down. I write everything down. Explain to the patient, right? They need to take a little bit longer so I can continue to see all the patients. Then I always go back. Do you have any questions? It's that important. Ya se va, que no se vaya. You want, no, wait. I get upset when they pull my patients. Bring them in. Do you have any questions? Did they explain everything to you? Do you have everything written? Do you have your meds? And with that, for the people following us, I just gave you a lot of pearls on how you can heal patients. Because everything that I'm saying is part of the wound healing. It's not magic. It's love and science, evidence-based practice, and expertise of over 26 years of treating patients. I want to introduce to you my brother, Ismael Lopez. You know what, before we do that, I'm going to do a real quick over here. Can we do it real quick, David? Because I know you're going to be pressed for 10. Volteme para acá. Acá, the video? On my video. And we're still live. So, I want to talk about the Comfort House, guys. For those of you that don't know about the Comfort House, this, if y'all just want to... I know y'all are going to walk. Those of you that don't know about the Comfort House, guys, ¿estamos filmando acá? ¿Sí? Bebé. Ah, okay. Que salga este señor aquí. Tell us a little bit about the Comfort House. This is my wonderful friend, David. I literally text him and I'm like, come to the conference. I love this place. My heart is for this place. They love patients. And I feel this is a very worthwhile place to talk about. Tell me a little bit about the Comfort House and then we're going to go to his mind.
Morning. Thank you for having us. Good morning, everybody. My name is David. I am the administrator at the Comfort House, which is right up the road. We are a nonprofit organization that has been providing 24-hour palliative care to individuals with the terminal illness with a prognosis of 3 months or less for the past 34 years. In the past 34 years, we've housed over 3,300 individuals. And, as a nonprofit organization, everything we do, the care we provide is free. So we survive on grants, fundraisers, and donations. And, Ms. Lopez here is a great supporter of ours, and she's always giving us kudos and allowing us to spread the word. So I'm very thankful that she is allowing us here today. But if any of you would like more information about who we are and what we do, I have information here regarding, the Comfort House and some of our upcoming events, and a couple of pens here in case you forgot yours at home. Thank you.
Thank you, David. So if people have a terminal illness, they go here and they're able to be taken care of for free. And they pass with dignity. One day we could be there gasping for air with no money, no insurance, and in pain. And so that's why I love the Comfort House and I love David. And thank you for being here. And now we're going to go and introduce my brother. God bless you, sweet. Ay, papacito, te pegué. Okay, that was on purpose for the show, so it can look like drama. I heard, David, that people like drama, and we have to do stuff like that. So I'm gonna go around slapping some of y'all. Just don't take it personal. That's right, baby girl. Oh yes, I drink Zoa at all my events because we're not sponsored yet, but I expect The Rock to call me at one point and say, April, you're always with your Zoa in your hand. You're always with your Zoa in your hand. You know what? We're going to sponsor what you do. I don't care if you don't sponsor. Just show up to an event. Okay, Ismael, This is my brother, Ismael Lopez. He's going to be speaking today. Ismael has been a PA for how long? Do you have the mic? Where's the other mic, guys? This is my mic.
20 years.
20 years. No. 20 years. Michael can come inside already, I think. So he can go next time. So I can do it, but I'm going to melt. Or maybe you can do it, but you're going to melt. Okay. I'm just going to give you my mic. I don't know where the mic went. You feel okay? This is. I'm very proud of my brother, Ismael Lopez. Thank you, sir.
Hello. So, like she said, I'm Ismael Lopez. I'm the younger, smarter, better looking Lopez in the family. Just playing.
He's my older brother. He's my older brother.
Anyhow, so a couple things. April, thank you very much for inviting us. Like she said, I'm Ismael Lopez. I've been in practice since 2003, a PA, and in cardiology practice since 2004. So I'm going to talk to you guys a little bit about carotid disease. Has nothing to do with wound care, but has everything to do with your patient. So we're going to go over that a little bit, okay? Couple things. Just to reiterate some points that April said, being a patient advocate, this is so important. You guys are wound care specialists. You're taking your time taking care of your patient with wound care. The last thing you want, they drop their pressure and they have a stroke because of an undiagnosed carotid disease. So this is what we're talking about.
And I'm going to interject there. Do patients develop wounds when they stroke out?
Absolutely.
This is why he's here. You stroke out, you're like this, you already have a dysfunction, you get a fracture in your hand, so absolutely, we know, your bedbound, stroke, wounds, right there.
Yep. So, as mentioned earlier, I've been in practice since 2003. I've seen a lot of different things. I've been involved with over 800 aneurysm patients in our practice. We take care of patients with carotid disease, pacemakers, defibrillators, aneurysms. I was a clinical coordinator for carotid stenting study. Back in 2008, we enrolled over 200 patients. I'm telling you all of this not to give you my CV, but I'm going to talk to you about TCAR, which of everything that I've seen in my career is what I'm the most excited about. Because it's a really, really cool and effective procedure. Okay? Oh, and by the way, if anybody has any questions, just stop me, throw something at me. This is very fluid. All right, so strokes, about a third of strokes are from the carotid origin. There's nearly 800,000 people in the United States that have stroke every year, and about 3 in 4 being the first-time stroke. So what does that mean? Undiagnosed people walking around, many different examples. You've all heard the stories. Hey, I saw someone fine, stroke. Wound, they can become septic. They can have an undiagnosed carotid stenosis. Drop your blood pressure, stroke, same thing. Which, by the way, to screen for carotid disease is a simple carotid ultrasound. When you send your patient for an arterial Doppler, same technician can do the carotid Doppler. It takes an extra 10 to 15 minutes.
What symptoms are covered for the diagnosis?
There's so many covered in diagnosis. There's not any particular ones. Risk factors: diabetes, hypertension, edema, smoking, PVD, bruits. But you guys keep in mind that bruits, are great. But if you have a completely occluded carotid artery, 100%, you might not hear bruits. So, and in bruits, you can hear them laying down, sitting up, whatever. So just order it. Worst thing they can do is say no, it's not covered. That's it. But 9 times out of 10. No, 95 times out of 100, if you order an arterial Doppler and the patient has other comorbidities, which they probably do, they're going to cover the carotid Doppler. So it's send the arterial to the carotid. That's what I do. Whenever I see a patient for PVD, I check the coronaries and the carotids. When I see a patient for carotids, I check the coronaries and the legs. When I see a patient for coronaries, I see the carotids and the legs. It makes a lot of sense. And like I said, the screening tests are so non-invasive and actually really cheap too. You can say something. So, okay, next slide. Absolutely. Absolutely. So carotid, usually silent over the risk. Next slide. You don't have it? No. The challenge of stroke prevention, it is estimated that every symptomatic stroke, there are nearly 14 silent strokes. This is why a lot of times when you see patients with dementia, you can see MRI findings, vascular dementia. There's different reasons why that is. This is one of what this alludes to is silent strokes, but so identifying carotid disease, symptomatic neurologic event, that's pretty obvious. They have a stroke or the carotid ultrasound. Carotid bruit, as I mentioned earlier, you might not always hear a carotid bruit. You have a completely occluded carotid artery. That's one of the pros that I always tell people about. Evidence of vascular disease, coronary disease, PVD, aneurysms. By the way, I also screen for aneurysms too. So it's the same machine. Carotid, ultrasound, same thing. And 2 atherosclerotic risk factors: hypertension, lipedema, smoking, family history. A lot of your patients can fall into that. If not all of them, a large percentage of them. Next slide. So clogged arteries and other areas increases your risk of carotid artery disease. This is the same thing I was alluding to, plus other risk factors including high blood pressure, high cholesterol, obesity, smoking, so on and so forth. Next slide. I'm going to slow it down a little bit when I get to the good part. So when intervention is indicated, well, sometimes we see patients from primary care offices, and then there's TCAR specialists, and that's talking about this. Do your primary care offices check for bruise? Some people do, some people don't. What is the process of identifying patients and funding them to a specialist? On the TCAR side, when do we intervene? What is the standard protocol? We'll cover that in just a bit. Next slide. So why TCAR? So TCAR stands for transcarotid artery revascularizations. Has anybody heard of TCAR here in this room? That's awesome. And no one has, because I can tell you guys about it. So transcarotid artery revascularization. I'm going to be talking back and forth about 3 different things. Well, actually 4 different things. When you treat carotid stenosis, there's 4 things that are done. Carotid endarterectomy, open up the neck, clean out the artery. Transfemoral stenting. Those are the people that come in acutely through the ERs and they go through the groin and put a carotid stent. 3rd thing is TCAR. Why TCAR? Why not TCAR is what we're going to discuss. Everybody should have TCAR, in my opinion. And 4 is medical management. Medical management if they have a massive stroke and depending on a lot of factors. So, okay, next slide. So TCAR, it's minimally invasive. It avoids the aortic arch, avoids cranial nerve, high rate flow reversal neural protection, and accurate stenting. I'm going to focus on these one by one, little by little. Okay. Go ahead, next slide. These are the 4 different things that we spoke about. Next slide. All right, right here we're going to compare TCAR versus carotid endarterectomy. Okay, next slide. Actually, go back. So TCAR, what we do in carotid endarterectomy, there's an incision that's made. There's a lot of structures in the neck that carotid endarterectomy. There's cranial nerves, there's facial nerves, there's muscles, and then there's the big scar, so that carotid surgery has been around for 40 plus years. It's been around for a very long time. It's still effective, but we have something that's bad. You guys have seen a lot of carotid endarterectomy patients that have issues, even shaving. They have issues talking. And then there's a cosmetic portion of it. Some people don't like very much a big scar. I know there might be some surgeons out there, I know a lot of them that are looking at this and say, my scars never look like that. I never make incisions like that, and I understand that. But there's still a lot of structures in that area. So I know there's a lot of great surgeons that are very meticulous with their incisions, so this is not a knock towards them. But we still have a lot of structures there that we're trying to avoid. So in TCAR, what we do is we make a very small incision right above the clavicle. Okay? Usually that incision is about 2 to 3 centimeters, maybe a little bit less. We avoid all the major structures in that area, and we do that to get access to the carotid artery, to the common carotid. That's right below the bifurcation. What we do after that is we insert a little catheter right in the carotid area, and we establish something called reverse flow. Reverse flow is when we divert the blood from going upward. We divert it downward, we pass it through a filter device, and we put it in the venous system, in the femoral vein. The reason for reverse flow, and this is what makes it safer than other procedures, is that while we're doing the procedure of the actual stenting, if any little piece breaks off or anything like that, it doesn't go upward, it comes downward, goes through a filter, and it avoids a stroke. Remember, in a carotid endarterectomy, there's a cross clamp that's done. That you clamp the proximal and the distal carotid so the patient's not bleeding, they clean it out, and then they release the clamps. So establishing reverse flow, this was very well studied. When I first found about this procedure, I thought to myself, oh my gosh, we're sucking the blood out of the brain. We're not. We're diverting blood flow. It is a passive flow. There's no suction. It's passive. And this was very well studied, because when you go to the FDA with a new procedure, you want to make sure that it's not more dangerous than the current gold standard, which is carotid endarterectomy. So one of the things that they did is they evaluated something called DW-MRIs, which is the most sensitive MRIs that exist. And they compared something called new white lesions when you have a cross clamp with a carotid endarterectomy, because you're decreasing the blood flow when you clamp. And they compared new white lesions to reverse flow. So they're comparable. What does that mean? That means that cross clamping and reverse flow are both equally safe. So once they were able to prove that, then everything else was approved after that. Okay, so once we establish reverse flow, and we are not sucking blood out of the brain, it's a reverse flow, then we can do the carotid step. Next slide. Now, these are just some numbers that came out of TCAR versus carotid endarterectomy. Less risk, 89% less risk of cranial nerve injury. 89% less risk of cranial nerve injury. 47% less risk of MI, less cranial nerve injury, less heart attacks. 48 minutes shorter OR time, and 12% less likely to have an extended stay past 1 day. Usually it's overnight stay in the hospital, in the ICU. We monitor all of our patients in the ICU overnight because of blood pressure issues. When you mess with the carotid bulb, sometimes we become a little hypertensive. Less likely hypertensive, but most often than not hypotensive. The following day, I usually go on discharge. Go to the next slide. The less invasive standard is stroke prevention. This I don't like slides that are too busy, but this pretty much just highlights what we said earlier. You know, everything that favors TCAR versus carotid endarterectomy, less MI, less risk of cranial nerve injury, less OR time, so on and so forth. Next slide. Okay. Which, by the way, if, we're going to go over there's no slide here that shows how we put the stent. After we establish reverse flow through the same catheter, we deploy a carotid stent. So it's very precise. This is looked at very carefully when we deploy a precise stent and then close the incision. That wasn't illustrated here, but that's pretty much what we do. Now we're going to compare TCAR versus transfemoral carotid stenting. This is something that I have a lot of experience with. I was, like I said earlier, I was a clinical coordinator for carotid stenting study. So a transfemoral stent, you go through the groin, you go all the way up to the carotid artery. Before you do the procedure, you deploy a little filter above the lesion, a little filter to catch any debris. Makes a lot of sense, right? You work and you do it, it catches. The filter catches. But every single patient that I saw that ended up having the filter debris, once the filter does its job, now what? You're pretty much left with a big carotid of sludge and clot and everything. So the filter works, but eventually you're going to have to suction, collapse that filter, and they're going to have a stroke. The other bad part of the transfemoral stenting is that you cross a lot of structures. Where you're passing through the femoral artery, you're passing the aortic arch, you're passing the carotid arteries, you're passing the lesion, and it's all unprotected. So you can hit this, hit that, hit this, any one of those things can cause a stroke. Transfemoral stenting has not been new. We've been hearing a lot of it recently because of the stroke programs that are available, but it's been around for about 20 years roughly, not more. So transfemoral stenting has been studied multiple times over and over and over and over and over. And the guidelines have not changed at all. The guidelines for transfemoral stenting have to be that you have to be a high-risk patient with symptoms. So there's very few, if any, outpatient people that have transfemoral stents. They all come in with a stroke. They come in with a stroke, but I always say, once you're having a stroke, the bar is set so low that you're already having a stroke. So you got to do a stent. It's either that or medical management or TPA, but no one likes to do TPA. So of all the times that it had been studied, you're talking about thousands of patients that were it has never been approved for an asymptomatic patient in an elective case. Never. For those reasons that they keep on having strokes. Transfemoral stenting actually has a higher stroke rate than carotid endarterectomy, which is kind of interesting. But right now, I don't think it's going to go away because you still have people having these strokes, But as I said, if anybody had worked in ERs with strokes, you come in, you have a time frame, you have this checklist of giving TPA or not. It's a window. More often than not, secretly, some people hope that they don't qualify for TPA, because when you give TPA, it's kind of scary. And then you end up having a transfemoral stent. So like I said, when you're having an acute CVA, the bar is already so low, they're already having a stroke, so you're going to have a transfemoral stent. But electively, on the asymptomatic, it's not indicated, it's not approved, and we have something that's more effective. So,
Sir, if I may. TPA, I'm going to say that is very scary, but it's very fun. For the ER trauma nurses, I'll never forget it. That's it. I get excited. You said TPA, I'm like, okay.
So yeah. So that's why I concentrate on transfemoral carotid stenting a lot, because I know it very well, and I don't think it's going away. Like I said, it's it's for acute strokes, but the purpose is for them not to have acute stroke, which is why you guys get treated, right? Next slide. Yes. So once again, when you compare TCAR is clinically proven to help less the risk of strokes and so much more. So TCAR, less chance of stroke. TCAR has less chance of a nerve injury, less heart attack, smaller scar, shorter procedure. Some of this is very repetitive, I know. Next slide. Indications and sedation. Next slide. So, up until, what was it? I want to say maybe about a year and a half ago. To qualify for a TCAR, you needed to meet high-risk criteria, which means you need to be considered a high-risk patient to be able to have TCAR. And there's a whole list of what's considered a high-risk patient according to CMS. And with or without symptoms. So we had to meet high-risk criteria, but you could treat an asymptomatic patient. Now, up until about a year and a half ago, I want to say March of 2021, all comers. That should tell you something. Whenever they changed the patient population, where we went from a high-risk criteria to now everybody, that tells you a lot. That tells you how effective and how safe this procedure is. So now we don't have to meet high-risk criteria. Anybody that has a carotid lesion, despite the fact that they're symptomatic, non-symptomatic, as long as it meets the stenosis requirement, we can probably address with TCAR. So symptomatic, usually if they have a 50% lesion and they're having symptoms such as a TIA, we should treat a 50% lesion and up, or asymptomatic, depending on who you ask. Some centers, some societies say 70%, others say 80. Just stick to 80. If it's 80, it's 80, and we'll fix it. Go ahead, next slide. Oh, excuse me. Go back. There are some anatomical requirements. So in order for us to be able to do this procedure, we need to have a certain amount of healthy carotid artery when we go in there. So, we can't go in there at the common carotid if there's a severe stenosis, which is going to be able to. You have an area of healthy artery. You got to make sure that it is not severely calcified, at least not what we call circumferential calcification, which means that the whole artery is completely calcified. I would say 90 to 95% of our patients that we evaluate are candidates for TCAR. I've been involved with probably about 110 TCAR patients already, and in all that, I can probably say we turned on maybe 2 because of heavy calcification. This is where we communicate with our surgeon and we say, hey, you know what, they would be better off with a carotid endarterectomy and so on and so forth. But more often than not, they qualify for this procedure. Carotid disease patient selection and approach. Advantage to TCAR, advantage to endarterectomy. You can't see the top part very well, but why think TCAR first? Same thing, reiterating the same point. Less cranial nerve injury, less MI, less OR time, less stroke rate when compared to transfemoral stenting as well. Next slide. TCAR procedure. So how do we evaluate a patient before a TCAR? Well, you need a carotid Doppler. That's the initial diagnosis. What we do is order a CTA of the carotids afterwards. In the CTA of the carotids, I look at my own images and I upload them to our Silk Road representative. They come up with a worksheet and make sure that they're a candidate for the procedure. The day it's recommended to be on DAP, dual antiplatelet therapy, which means aspirin and Plavix or aspirin and Brilinta. Yes, ma'am.
I have to say this, as nurses, because everybody's watching, right? And these videos are going to be uploaded to our channels forever. I'm saying indefinitely. So, we get very scared, Mr. Lopez, Ismael, when we see Plavix, aspirin, and I was gonna say Cialis. One of the friends.
Celostasol?
No. Yes, Xarelto, Eliquis. People are taking those. No, you can't take all this. There are blood thinners, guys. There's people on all three. Do not, please, family out there. I'm not doing you have to buy Bluetooth for me to come out with here. I'm just kidding. You can't just take people off their meds. Okay? Family out there, please don't get off your meds because you're like, this, I don't need this. You're gonna come in with an occluded foot or you're gonna have a stroke. So, can you just tell us, like you tell me about the dual antiplatelet? Yeah, I know it's a little off topic, but what would be some cases where I would have a patient on aspirin, Plavix, and say one of the Xareltos?
So remember, every sometimes we say the term blood thinner, so we can better explain ourselves to the patient to get the point across. But in reality, blood thinner, every single medication works completely different. Some of them work on platelets, some of them work on certain factors, and so they work completely different, which is why a lot of times you can use different agents in conjunction. That doesn't make it safer, less scary, but you can. We try to avoid certain situations where they're on all three, so it's very possible you can have a patient with AFib that needs one of the NOACs, such as, can I see Brian? Eliquis, Eliquis or Xarelto.
Somebody asked us, are we getting CEUs? I don't like all that red tape, okay? We get CEUs, it's very easy for me to renew CEUs. Then I can't have whoever I want in the booths, and everybody has to say disclaimers, and that's not what this is for.
Good.
Okay? The conference is free to you guys. We give lunch and breakfast. We network, we hang out, we have awesome speakers. Nobody gets paid. I don't get paid. I pay for all this out of pocket. Some people get us, Mayo's not gonna get paid, no. I'll give them a Starbucks card. So we're not doing this for all that red tape. We are doing it to network and learn. Then we don't get as much as we can.
To go back to the original question, what is the situation of Bushman? AFib is the number one arrhythmia in the country. A lot of people have AFib. Every day I see 10 to 15 patients with AFib. They need NOACs, Eliquis, and if they have vascular problems, such they had a recent leg stent. There you go, a recent coronary stent. If they had a recent coronary stent with AFib, that's already aspirin, Plavix, and Eliquis. Now, mind you, this is a whole other subject. Some of the newer stents in the coronaries are more forgiving, so we can get away with less time with that than otherwise. But so yeah, there's certain situations that you do need to be on all three, and we're receptive to that. We're conscious to that, which is why sometimes there's very specific rules we follow, if you will. I personally, when it comes to AFib, if I see somebody that has a lot of vascular problems, and I think they're going to keep us busy with a lot of procedures, I try to get them to have something called a Watchman procedure, which is a little filter in the left atrial appendage that is done through the venous system, through the groin, and it eliminates the need of Eliquis or Xarelto. I'm a big advocate of that. I have a bunch of patients who have had a Watchman, and it makes my life a lot easier, and their life easier. So if I have someone that I think is going to have a lot, I just send them up for a Watchman, and then I can safely relax and give them aspirin and Plavix as many times as they need to without worrying. And those of you who don't know about Watchman, go to our Instagram page.
Gomez family. Let's talk about that Instagram page.
Yes, it's Gomez Cardiovascular.
Ismael Lopez doesn't bring cards. All my doctor friends, Dr. Farias just walked in. Doctorazo, pásale para acá. Doctor Farias. Un placer, doctorazo. Estamos en el canal de YouTube y Facebook, siéntese donde guste, ¿verdad? Iba a hablar mal de usted, hombre, acaba de entrar. I was going to talk bad about you. Doctors don't bring their cards. They don't want you to know who they are, I guess. I'm like, do you want a boot? Nah. Bring something, bring a card. So, Dr. Reyes, do I have nothing? Ismael didn't bring cards. Ismael, where are you from?
If you guys need my cell phone, I think we're all here to help each other.
Yes.
So if you guys have any questions, just at the end of
where are the clinics, Ismael? Where are the clinics?
So just feel free. There's a lot of providers that I know, other Ps and NPs that work in primary care and internal medicine that I have a very good relationship with. Like I said, I've been in practice 20 years almost in cardiology, so I've been there where I look at an EKG and when you're first starting out, it's a little scary. So have a particular scenario that you're not sure what to do with, feel free to call me. Even if I'm not seeing the patient, what have you. I get EKGs from different people in the valley. Say, hey, what do you think about this? This is what it looks like, so and so. So feel free. I didn't bring my cards, but get my cell phone. Talk to me. And I'm available if you guys have any questions on other patients. So I work at Gomez Cardiovascular Clinic. We have 2 clinics, one in Brownsville, one in Harlingen. We have Instagram and Facebook. It's under Gomez Cardiovascular, both Instagram and Facebook. There's a lot of different little things there that you see about a lot of the different procedures that we offer, a lot of different services that we have, and we're pretty complete clinic that we offer a lot of different services. Right now, our office can pretty much handle any type of cardiovascular problem head to toe. So if you guys have any carotid stenosis patients, coronary artery disease patients, pacemakers, defibrillators, aneurysms, peripheral vascular disease, that Dr. Gomez will speak about in a little bit, venous problems, venous stasis, varicose veins, all that stuff. We pretty much can handle all. And if we don't have something available, we have a streamlined process with some of our colleagues. So for example, we don't do Watchmen, but I have 2 colleagues of ours that do this Watchmen, and we have a very good relationship with them. So whatever you guys need, just feel free. But I didn't bring my business cards. Anyhow, back to carotids and also back to the T-card. So T-card procedure is considered not safe if you're not on aspirin and Plavix before the procedure and after. You should not do it. So right now, the current recommendation is to be on aspirin and Plavix or aspirin and Brilinta for about a week before the procedure and a month afterwards. Okay, the carotid arteries are bigger than the coronaries; they're more forgiving. So the antiplatelet therapy is usually shorter than when it comes to the coronaries. I personally am a little bit more aggressive with ADAPT. I've been around long enough to know that if something is working for me, I kind of don't change it. And also when I see guidelines go back and forth, it makes me a little nervous, so I just stick to what I do. I usually start aspirin and Plavix about 2 to 3 weeks before, if possible. If it's only a week, I'm okay with that. And then afterwards, I go all the way 3 months. I mean, right now the current recommendation is 1 month, but most of the time, if they can do 1 month, they can do 3. That's worked for me. We haven't had any major events. What we've been doing in the transfemoral stenting trial that we did, I remember one of the questions was a patient on DAPT before, how long, and was a patient on DAPT afterwards, and how long? And they asked that for a reason. So I've noticed that for me, 3 months is yes, aspirin Plavix. That being said, there's very specific times. So just the other day, there's a patient that had AFib and had a carotid stent. So on her, I stopped the Plavix after a month. Because it's perfectly safe. So you definitely need at least a month and at least a week. I personally don't live better than that. So because of that, we have a lot of things available. All the nurses in the hospital, everybody knows aspirin Plavix, do not stop it the day out, do not do any of that stuff. Because they go pre-register and they stopped it on the no for a week, we're going to have to cancel your procedure. Well, you can potentially reload them with Plavix, 600 milligrams of Plavix, but I'd rather just cancel the procedure, let them cool off, and then restart. Okay, next slide. So these are the same guidelines that we're talking about. Statins as well. Statins, I didn't mention that, but it says 5 days prior. Most patients are on statins anyway. Go ahead, next slide. Next one. Post-op care. Go ahead, next slide. So this slide deck that I think is going to be available is a very extensive slide. I went into the middle portion of the slide deck, but if you guys wanted to look at the whole slide deck, from start to finish, it goes about how to start up a T-card program, how to do it, what you do, how to reach out to patients. There's even some areas that is more tailored to some physicians or the operators about the particulars of the procedure itself that I chose not to speak about today because it's, the very particulars of the procedure, like how long to clamp the artery for, so on and so forth. I don't think we need to know. So after the procedure, they usually go to the ICU overnight. More often than not, they become a little hypotensive for a couple reasons. When you're messing with the carotid area, that controls our blood pressure, the carotid stent tends to expand for about another 24 hours. It expands slowly, so there's that period about 24 to 48 hours that they can become a little hypotensive. Some people, what they do is they hold their hypertensives before the procedure. I don't, because I rather deal with hypotensive than hypertension after a carotid procedure, because you're potentially fixing an artery that had 80-90% stenosis, and then you open up the artery, and then if they shoot their blood pressure, they could bleed. That's called a reperfusion injury. You guys see it in legs, probably. A little pearl on the wound care. You guys send a patient for vascular intervention. A lot of times after the procedure, there's edema. Why is there edema? It's a reperfusion injury because now you're improving the blood flow, so it takes a little while for the limb to accommodate. Imagine that in the brain. So I'd rather give them their antihypertensives and I'll deal with the hypertension afterwards, give them the relief or what have you afterwards, because I don't. So a lot of times I send them home the next day. I hold their antihypertensives for a day or two. I usually send them in the office shortly, and then leave them alone after that.
Mr. Lopez, I want to touch on that, on the reperfusion injury, because we see this a lot. People get scared, right, Dr. Fayad? They have a dry foot, they have a dry limb. We call it a dry foot because there's no flow. They're used to it. And then you revascularize. They're in the hospital. And then I go back the next day around, and they're like, this doctor messed me up. My leg is swollen, they made it worse, and now I have another wound. So the reperfusion injury, if you could just touch on that one real quick, just like why it happens, it's not bad. It's not bad. Now you have flow. And then I get the complaint, well, now I have a lot of pain. I didn't feel it. Now I'm like, that's a good thing because your foot's alive. Oh, well, now I'm bleeding. Well, that's a good thing. Before we were going to cut your leg. So this is why we're explaining. Just real quick on that one.
So it's plumbing. The limb was not getting enough blood supply for who knows how long. You open up the blood flow, that's it. Very simple concept. It takes a while for the limb to accommodate. Movement helps a lot. It was very, very common. Not everybody gets a reperfusion injury. A lot of factors contribute to it, but mobility helps a lot. So that going back to the point of the brain, you can have a reperfusion injury to the brain, and when you bleed, you bleed. It's not a good day for anybody. So I personally rather deal with hypertension post-procedure than hypertension post-procedure. You might not read about this a lot, but when you're dealing with a patient with uncontrolled hypertension, I've seen it a lot of times. Carotid disease does contribute to that. So I've seen patients where we fix their carotids, and a lot of people are going to disagree with that. Disagree with me on that, but this is where clinical practice comes into play. See a lot of people with 4 or 5 antihypertensives, we do their carotid and they're down to 3, So it makes a lot of sense. So anybody with uncontrolled hypertension, I screw their carotids anyway. Next slide. Same thing, dual anticoagulant therapy, stand therapy. Next slide. Okay, next one. Like I said, this is a very expensive next one. Okay, that's all. I have this video that I put on this. Do we have access to go on our page and look at a video from here? Yeah, Instagram. There's a reel on there that shows the video. Yeah, so there's on our Instagram page, there's a little reel that says T-card. And you just click on that. And I mention a couple brief words, and there's a video of how the procedure actually is. So it's a small incision above the clavicle. You get access to the common carotid, establish reverse flow. We deploy a carotid stent, which is very precise, and then we close the incision after this. So one of the questions that might arise is, what's more effective long term? Carotid endarterectomy versus carotid stenting. We have enough data. If anything that transfemoral stenting brought us is we know that they're effective long term. It's been around 20 years. Carotid stenting is not new. It's been around over 20 years, I would think. And we know enough that if it's done properly, sized properly, and take the medications properly, long term, they're just as effective as a carotid endarterectomy. What happens is if a carotid stent's restenosis, we can put another stent. It does happen. It does happen. Usually if it happens, it's either because they didn't take their medications, very uncontrolled diabetic, smokers, so on and so So TCAR all day, every day. Does anybody have any questions? That means I covered
Ms.
it.
Lopez. Questions? Okay, Gomez, what is it, Gomez Cardiology?
Gomez cardiovascular.
Gomez Cardiovascular in Harlingen and Brownsville, we'll put it on the links. We are here because we want the nearest, go ahead.
Last thing, I'm so sorry.
Yeah, go ahead.
You guys that do a lot of primary care, I'm gonna say this again, screen. A lot of times, when you work, there's, surgeons sometimes are very, they have a lot of volume, they need to focus on the problem in front of them. So they have maybe, 5-6 procedures that day, plus tomorrow another 5-6 procedures. They're fixing the problem that you sent them. They're not necessarily finding the problem. And that's not bad to I'm not saying anything bad about the surgery, that's just how the system is designed, that surgeon fixes the problem, right? Sometimes an interventional cardiologist fixes the problem. But you guys are in the front lines where you're the ones seeing the patients, you guys are the ones doing everything, so that's where the screening comes, And there's some people that might say, hey, why are you screening if the patient looks perfectly fine? Well, because if it was my mom, I'd want her carotids to be screened as well. This goes back to the point that April was talking about, being a patient advocate. So screen. I think that's the biggest pro that I would tell you guys. And honestly, that's it. That's all I have. Anybody have no questions now?
And regarding that, and he'll give you his text, his number. Regarding that, we're expected to. For those of us that are all the nurse practitioners, the way we get trained, primary care physicians, I don't know if doctors, primary care physicians, the primary care physicians that practice, we're expected to, we have guidelines for screening. We have a whole app that tells you based on the age what you're supposed to be screening for. So this is a great procedure, and this is a great idea to do this versus always going straight for the carotids, depending, like I know you guys consult the surgeons when we need them. And the other thing I was gonna say is, we're supposed to be going to conferences every year, guys. I know I was like, I hated doing the online ones when COVID, but we are supposed to be staying on top of our practice. So I go to a conference, I love it because I get to write it off, but I try to go to a conference 5 times a year, if I can. So we go, right? We go twice together. So I do the TNP ones, and then I do the AANP one, and then I do 2 wound cares. So why? Every time we go, right, Amor? Every time we go, I'm like, oh my gosh, and I'm texting the guys, we're gonna do this, we're screening for this, print it all out. And then when I get back to the office, I have like all these stats, like, why? Now I have to review them and put it and implement the changes.
April.
Yes.
We have a question.
We have a question. Yes, Robbie.
Oh, okay.
The number. I'm gonna put the number out there public, just kidding, cuñada. My brother. Any actual questions for Chica? Go ahead.
Our program is unique. And I've done some lectures on TCAR in different places, in Philadelphia and other places, in Florida. And our program, I think, is unique, and in the fact that we have the interventional cardiologist and the vascular surgeon scrubbed in together. In the unlikely event that the TCAR, a lot of times interventional cardiologists, they have, certain tricks they have with catheters on crossing lesions, so on and so forth. But in the event that a TCAR procedure is not successful for one reason or another, because of heavy calcium burden, we don't just send the patient home. We just convert it to a carotid endarterectomy at that time. Yeah, the surgeon, and it's a very good. So this is a team effort. Our team involves a surgeon, cardiovascular surgeon, interventional cardiology. The patients usually come through us. But our team is unique in the sense that we have both people scrubbed in together. So I think it helps a lot.
Y'all can go to the booth in the back. You have more questions, we're gonna pass it on. Very good, thank you, Mr. Lopez. So now I'm going to
Introduce our wonderful ¿Sí? Hacemos el setup, ¿verdad? Si quiere abrirlo. I'm gonna do one para que se prepare el doctor Farías. Y nomás ya que lo tenga abierto y todo, let's do mine real quick, sweetheart. I'll do mine, and then, you're gonna send a case, right? And then we'll open mine. We can open mine and then while you send it. Is mine in here? That's okay. late last night, I posted a video on that, and I was out barefoot, we were putting up the sheets. ¿Lo ponemos? Amor, él es mi prometido, doctor Farias. Doctor Farias, le ayúdame, amor. Él tiene un regular HDL. So es este, ¿no? Este. And I get here, and we set up the tables were set up, but I walked in and estaba medio seco. It was kind of like, I don't know, they just all black boots. So we went back to the office and I bought some fall stuff. I love the fall. And we decorated a little bit and stuff. And I just put the shirts on. All the shirts are for you guys. Take the shirts. That's what they're for. I'm not going to take them back to the office, or take them with you and give them away. We don't want it. I never take anything back. And the chocolates, please eat them. If you want more, I love chocolate. Like, I put out what I have. I like black coffee, and I haven't eaten. So if I want to, I usually try to fast till 2. need to go back to your doctor and ask them, can you please help me do this? If they don't want to do it, you need to get somebody else that will do it. Because I work for you. You don't work for me. I work for you. I have to help you. So how do wounds heal? We go on to the next one. Let me talk about that previous case. Go back. This particular lady was a surgical wound. Every single picture that you're going to see are our actual patients. We have brochures on the table that y'all can also take. These are our patients that healed out. We have a team. Dr. Farias, I'm so proud to be his team member, and Dr. Farias means a lot to me because he's always been very supportive of our program since we started. Nothing but good vibes. But more than anything, I'm appreciative of Dr. Farias and Dr. Reyes. I have a hospitalist group. I actually now, as we expanded, heal. I have to have the following people on my team to be able to heal patients out. Number one, I have to have me. I have to have me. I have to have a good, I'm the wound specialist, right? I have to have a good primary care physician. I'm a nurse. Above everything, I'm a nurse. And I always tell people that's what my experience as a floor nurse and doing wound care all these years, and that's what has really helped me heal out the wounds, because I'm not afraid to try something else. I'm not afraid to refer out. I have no chips on my shoulder. I have no ego. Unless it's my wound. I always tell patients, this is my wound now. Don't let anybody touch it. Don't change my order. And come back for follow-up so you can heal. That's all I ask. Okay? If you go see somebody else, I discharge you from the practice. I do not ever take patients back, because wounds are very sticky, and I don't want my name behind what somebody else messed up already. And then they're like, I was even with Lopez. I'm like, you left. You left, you come back, I can't see you anymore. You fired me. There's no good rapport there. If they don't trust you, if they fired you already, you're not, no me tienes fe, you're not going to do well with me. We have to have good rapport. Just like you could fire me, I could fire you. So you fire me, we don't take patients back. Why? Because then they come back with all this stuff. I don't know what they did to the wound, and I have to pick up where I left off. It's usually not a good outcome, because those patients are like going to multiple doctors, practitioners, and then we don't have a good outcome. So once I put my hands on the wound, that's not my foot, my wound, my leg. This particular patient was one of our ladies. This is a post-surgical wound, non-healing surgical wound. For a staging and all that, when your patient hasn't healed for 30 days, it is now considered a diabetic ulcer, non-healing ulcer. The etiology of the wound really does not matter if the patient is diabetic. Okay. This particular patient was a dehisced surgical wound. Clearly, it's infected. Clearly, there's cellulitis. You see fibrous lock. This is a shin wound. This was a very particular case because this patient had healing in the middle. You see the little middle part? That's healed out. And then she had that opening, and then I could stick the Q-tip through the bottom like this. Acá, señor Carlos, acá. Vamos a checar si tiene otro adaptador para acá nomás. Gracias. Enséñale todo lo que tiene el doctor. And pardon me, guys. And so we have a case where no me están bloqueando las cámaras, ¿verdad? Señor López, dígame.
El doctor
bueno,
Rama.
hay que decir. Okay. Entonces, the Q-tip went under, and so the whole bottom part was open, and then it went out that way, and she had a tunnel all the way in. So I have to send this one to him. This was probably one of the cases that I sent. And guys, I refer to anyone. I always tell the people, number one, where do you want to go? I work for you. Do you have your surgeon already? Who is your PCP? I don't take patients, guys. I do primary care. I never accept a patient that was my wound patient as primary. It's not good business. I've had them come back a year later. Tell them, I cannot see you. You need to go see your primary. They come back 6 months later. Okay. I cannot take people's patients. I only do the wound care, send them right back. I cannot handle either the primary care and the wound. Why? If they're mine already, but I'm saying the wound has to be managed as the wound, and I need your primary to manage your diabetes, your hypertension, your lipids, everything else, and then I need your cardio to manage your PVD. That's my team so far. Myself, the wound specialist, the PCP, the cardiologist for revascularization issues, cardiac issues, then I have an infectious disease. If I do a punch biopsy and it shows that there's infection, or if I know. If you have a bone sticking out, do I have to have an MRI to know I have osteomyelitis? I have the bone sticking out. Unfortunately, for insurance purposes, I have to have a documented osteomyelitis. And sometimes I don't get to get the MRI. All I have is an x-ray that's not sensitive enough that I've seen a bone sticking out and it doesn't say it has osteomyelitis. And then when my surgeon over here, Dr. Faria, says something like, it has spongy bone, I have to go and fill it. What I love about that group, Dr. Reyes and Dr. Farias, is that they only do what the patient needs. There's still people that do stuff the patients don't need. How many of y'all know that in medicine it's a business? And sometimes people act like it's not, but it's a business. And so unfortunately it's based on volume. And a lot of times patients get procedures that maybe they don't need. We get a lot of this with, depending on what specialty you're in. I always tell people, if you have a taqueria, you're gonna sell me tacos. Right? I have a knee that I tore my ACL, MCL, and my medial and lateral meniscus. And, for sure surgery, right? Total knee repair. Total knee repair, right? No. Heck no, not if it's my knee, not if it's my patient either. Therapy, red light therapy, massage, heat, prayer, vitamins, lots of therapy, good exercise, not bad exercise, no exercise there for a little while, bandaging for sure, knee brace, all the good stuff, and it's almost completely healed. If I went to the ortho, it texts them and goes, I can get you in next week for the surgery. You haven't even seen me. I don't want my knee replaced. Can I have some conservative therapy? It doesn't pay as much to do conservative therapy. How many of y'all know? This is what we have. This is the nitty gritty, guys. We look the other way. Who rounds in the hospital here? I rounded it. Who has worked in the hospital as a nurse? Don't tell me you haven't seen it. Have you not seen it? I've had to cancel surgeries because my patient did not have informed consent. Who gives informed consent, nurses? I hope all the nursing students are learning something. Who gives informed consent? The nurse or the doctor? I'm not talking about nurse practitioners. Informed consent is given by the doctor. The nurse is only a witness to the consent being signed. So before you as a nurse have a consent signed for a procedure, you must ask your patient, do you know what the doctor's going to do to you? Did he explain to you what he was going to do? And did he explain the risk factors? No, I don't know what I'm going to get done. Your patient needs informed consent. He will be very angry. I'll never forget. I tried to get informed consent. I happened to work night shift in the tele floor. I tried to get the doctor to come in and give the patient informed consent. I'll give it to him in the morning. I said, okay, well, give him informed consent in the morning. Have somebody else sign the consents. I didn't tell him that. So I didn't sign the consents. I told day shift, the patient's scared, they don't know what they're doing. I can't have them sign the consents. Why do you have them sign the consent? Because, the doctors are gonna get mad. It's not my problem. Yep. Those of you that have rounded with me in the hospital know that I'm not concerned about upsetting people if it's a patient advocacy issue. You have an issue if you are not advocating for patients in the hospital. And the reason why I work with Dr. Farias, it's because he does. And I'm not a doctor, I am a nurse. So, with that being said, this particular patient, what did we do on her? She did not, I would have loved for him to have opened it all up and cut it all open so I have a beefy red wound. That's easy, that's already, see guys, it's, when you send me a beefy red wound, it's easy to peel them out from there. They're never beefy and red. They're either black, dry, and hard, or with osteomyelitis, or with worms on them, or they have a black, dry foot, or they're like this. And I'm like, do you want to go see my surgeon? I have a friend that can, just, no. I'm like, come on, you're going to make me work. So then we did Santal on her, we did hydropheric glue, we did weekly debridements, sharp debridements, we can debride when we're board certified for wound care. You have to take into consideration pain. She healed up. Look how beautiful her scar is. Okay? So we go on to the next slide. These are the objectives, guys, to understand the role of each of the 9 essentials of wound healing. If you don't have one or any of these, you're not going to heal. You can jump up and down, you're not gonna heal. Perfusion, unviable tissue, inflammation, infection, addressing that, edema, wound microenvironment, tissue growth, offloading, pain control, host factors. Can a patient heal in pain? No. Will the patient move in pain? No. Dr. Michael's gonna talk about the importance of mobility. Next. Adequate perfusion, Ismael talked about the carotids, perfusion everywhere. Claudication, cramping, pain, or tiredness in the calf, thigh, or hip while walking. Diminished extremity pulses, tissue loss, ulceration, gangrene, or rest pain. Can a patient heal without plumbing? If you have a wound there, no. So you have to open the faucet of the blood flow of the plumbing. Right? Next. Adequate perfusion, we talked about this. You look, there's basically a lesion. Go to the next one. Epidemiology, this is very important. Framingham Heart Study suggests that 20% of symptomatic patients with PAD also had what? Diabetes. How many of y'all know that we all have undiagnosed diabetes in the valley without anybody knowing? The majority of the patients walk around and like, I'm not diabetic. And I'm like, I'm looking at you, you're diabetic. I'm looking at you with the acanthosis nigricans. I'm gonna date myself again. I was one of the nursing students that did the study, the clinical study for the South Texas-Mexico Board of Health at UTPA for acanthosis nigricans. Who knows what AN is? Who's a school nurse? School nurses? Acanthosis nigricans is the thickening, the darkening of the neck, of the axilla, sometimes here, sometimes in the groin. All it means is hyperinsulinemia. Well, we didn't even have a code for hyperinsulinemia as a diagnosis. We didn't know what acanthosis nigricans was. We thought we were gorditos and we had postrita. It's true. Grandma used to be like, you need to scrub that off the patients, and that's not good. They're dirty. We're not dirty. It is, and it causes a thickening. Have y'all also noticed there's a lot of skin tags surrounding that a lot of times? I don't know. There's no data on that, but it's a clinical, like Ismael said. I'm going to tell you, there's a lot of stuff that I do that's database, and we saw this in COVID, and those of you that have followed us on Facebook and on our pages know we've treated thousands. We've treated thousands of patients for COVID. We have an electronic medical record, and we've treated over 3,500. We should run it in because we have another, right now there's another spike. But people are not dying, not my people. We treat them right away. And I actually still mask only in the clinic just because out of respect for my elderly. I'm doing reverse isolation now for my elderly, because is every patient with a wound immunosuppressed? Yes or no? Okay, how's that going? Is it going or no, mi amor? Si no, so we can go get the adapter. So, acanthosis nigricans, hyperinsulinemia. All you have to do is draw a level, blood level, it'll show increased insulin. Is it going to show an elevated hemoglobin A1C? No, it's not going to show an elevated hemoglobin A1C. It's going to show an elevated insulin level. And I've seen this, and we've seen it in kids. Have we seen hypertensive kids? Yes, we have. So it became part of the screening after we did all the research study and had to compile all the data. It took about 2 years later, and then I saw that it went through, and the AN, and it was a big deal. I still have all the original papers. I'm a paper person. If you want to see them, I'll post them on my page. So, are people walking around with undiagnosed diabetes? Yes, that kid is one step away from diabetes. So, if you see PAD, think diabetes, okay? We're going to go on. So, as y'all can read it on the next. And this is one of our patients. I think it's funner to go to the wounds and give you guys like actual clinical. So, back to the clinical. So, during the COVID pandemic, we all know that there was meds. There was no meds, first of all. First, we had no PPE. Then we had no testing. So, what were we doing? We were frontline, looking at you like, I don't know what to give you. You could die. Stay home. So, a lot of patients were told, stay home and die. And that's not how we worked. We actually we have a very extensive COVID protocol that we used good drugs that were safe for patients that work and still work. I just gave some to my kid last week. And for those of you wondering about that, doctors did sue the FDA. They did win. And it was very clear, we already knew, that practitioners that have prescriptive authority are allowed to prescribe off-label. They've always been allowed to prescribe off-label. It is legal, and doctors have a right to prescribe a medication that people don't want prescribed, IVM, for COVID. It's their legal right. And it's a patient's legal right to seek healthcare elsewhere if they want it and they don't get it. So there's that, and I'm very proud of that. So this particular patient, so I am unintelligent enough to understand that when I see something's working, I'm gonna do it again. Does that make sense? I feel like I want to research, but especially in the face of COVID, it told us very clearly. What drives research? Money. What drives research? Money. If I don't have millions of dollars, or at least hundreds of thousands, nobody's gonna pay for my research, yes? Nobody wants to do research on cheap things. I use very inexpensive powders for the patients. People call them the magic powder. It's not cocaine. There's a lot of powders. There's Eblisan, there's Dextrosan, there's Dextrotex. There's a lot of different powders that people use. There's old powders that have been used. They don't make any money, okay? So a lot of the protocols I implement are my protocols that I've implemented in my clinic with a concept of if it's wet, you dry it. If it's wet, you dry it. If it's dry, you wet it. That's the same concept. How do I get this wound to where I can wet it if dry, dry it if wet? I can't do it if it's a black, dry, hard necrotic. Does this wound look wet or dry to you guys? Initially. Wet. Look at the top. The bottom was healed. Look at the top. It's wet. How the patient got it really doesn't matter. It doesn't matter to me. I want to know the etiology, but most of the times by the time I get it, I have to know the etiology. I have to know the comorbidities. I have to make sure they're addressed. If they're not addressed, they're not going to heal. My point is, once I get that wound, look at medical history, look at the meds, get the etiology, then I'm just looking at it. Is it wet or dry? Is it infected? Is there flow? This is a flow, ABI, right? And now it's like, okay, ABI, carotids. I'm thinking. So we have to get rid of all that. How do we do all that? We do sharp debridement. We do enzymatic debridement. We do mechanical debridement. We after we finished using the enzymatic debridement, then we went to the powder, and then boom, she healed up. This was a burn. Okay? So very important. If you're a diabetic, there's a far greater chance of PAD than in non-diabetes. That's understood, right? Okay. We go on. Next. This is very important. Refer early. You have to refer early for assessment, save a limb, save a life. Nobody wants their legs cut off, guys. This is an amputation prevention conference. We want you to heal and keep your legs on. Heal and keep your legs on, okay? Would you guys like to be walking around without a foot, without a leg? They won't leave you without a foot. They'll leave you without a leg. You have to be proactive and aggressive. You want to heal the wounds fast. Fast. You want to heal them fast. A lot of times when they teach us about business and they teach us about having a clinic, guys, you gotta understand that there's people that make money off of teaching you how to make money in the clinic. There's nothing wrong with that. I love capitalism. There's nothing wrong with doing well while doing well for people. There's nothing wrong with doing good while doing good, right? Why should I not do good if I'm doing good for people? I should be doing the best. That's God's promise to his people, right? But a lot of times we forget that when we work on volume, things can fall through the cracks. One of the things that I was told when I was working for the doctors, now I own my own family practice. For those of you that just joined the feed, the live feed, and are going to see it later, April Lopez, Lopez Family and Wound Healing Clinic. I am a board certified family nurse practitioner, adult geriatric acute nurse practitioner, certified wound specialist, and certified skin and wound specialist. When I was working for the doctor, they're like, don't do it everything at the same time. Like, what do you mean? You're taking too long. I would take too long. I'm like, well, hold on. The patient's coming in. He's a 45-year-old male. He's never had a workup. We're reviewing the labs. He's diabetic, hypertensive, high lipids. He's having shortness of breath. He's having erectile dysfunction. He's a smoker. He's a drinker. He has fatty liver. You want me to not send to cardio for a workup? Not do what part of a screening? What should I not teach on? The hypertension, the lipids, I have to give a statin. I have to give metformin, potentially maybe a GLP-1 and SGLT2. On the first visit, I have to talk about obesity, diet, meds, exercise regimen, sexual habits. Don't go take Cialis. I have a thing. I don't keep talking about Cialis for a reason because my patient he was texting me yesterday about it. I send my patients for a cardiac workup. Should you be doing a cardiac workup on high-risk patients prior to prescribing Cialis? Should you be getting one prior to taking Cialis? Have you ever had a patient fall over dead of an MI on Cialis while having sex with their girlfriend? Because it happens, and it's not going to happen on my watch. Why? Because I'm a patient advocate. You're paranoid. That's my husband, you better send him. Right? So, you have to work the patients up when needed. You have to send them early. You have to go, guys, if you're a nurse practitioner, you have to go to conferences every year to learn the newest changes. In whatever specialty you're in, you don't have to go to 5 like me. I also do the NTI. So I have to do NTI, ANP, TNP, and wounds. Now I want to do the plastic surgery that I did. So I want to see what else I can do in my face later. So I want to do Botox. But they have a lot of new stuff. She thinks I'm crazy. I want to do Botox. So you have to stay up to date with the newest things. Things change every 6 months. Like in my saying, you was talking about the guidelines. They go back and forth, they go back and forth, they go back and forth. Yes, they do. We need to be aggressive, and if we don't know what changes, how are we going to know what the newest thing is for our patients? You have to go. And I love going. I know that everybody can go, everything's online now. I never pay attention, I just go next, and get the CEUs. So I'd rather sit somewhere and actually learn and implement. So referrally, next. This is important. 2020, I have to update this slide. 2021 CDC, 2020, let's go. Next. And these are the results. You can't really zoom in on that. Basically, it tells you guys, I'm going to post these on the page. Basically, it talks to you about the percentages of men, women, and children. Basically, it's getting younger and younger. Okay? It's getting younger and younger. There's more disparity. Next, Mijo. There's more disparity in, of course, the Hispanic and the African American population. So we have a higher risk. And it talks about diagnosed versus undiagnosed. This is not accurate. There's a lot more on that. How could you know what's undiagnosed if it's undiagnosed? They're doing a guesstimation. Next. This is when I tell you that common sense is not so common anymore. I need a double-blinded research study to show me that this powder works on my wound. And if I don't read it, I'm dumb enough not to do it. Because I don't have a study, and I'm not going to do it because I have no clinical sense. I have no empathy for people, and I have not one cell that works in my cabecita, in my brain, unless you give me a double-blinded study for a product. Come in, sweetheart, I love you. Oh, this is open. For a product that doesn't pay. Who's going to do a double-blinded study on a product that costs 10 cents? But it works. But I'm not going to do it because I don't have a double-blinded study. Just for that, I want to do research and throw it in people's face. Then your double-blind study. It worked. I'm looking at it. Thousands of patients I've healed. Just throw it on the patient. It's not going to hurt. It's a medication. It's an old powder. Each year, approximately 200,000 non-traumatic amputations occur. Doctorazo, pásale para acá. Ya llegó el doctor Reyes. Pásale. Dr. Luis Reyes, everybody, let's clap for Dr. Reyes. We love you, Dr. Reyes. Otra eminencia. We're just gonna have to go get an adapter. That's the fastest thing. Let's just go get one. But we'll probably take the computer with us. Each year, approximately 200,000 non-traumatic amputations occur. That's not okay. I'm going to stop right there. 200,000 non-traumatic amputations occur every year. Of course, African Americans are 4 times more likely. It doesn't talk about Hispanics, but we're right behind them. Anytime you see anything African American, the disparity, the Hispanics are right behind that disparity. Okay, they're 4 times more likely to experience diabetes-related amputation. In the U.S., every 17 seconds, someone has a diagnosis of diabetes, and every day, 230 Americans with diabetes will suffer an amputation. Think about it. Today, 230 people will lose a leg. Tomorrow, another 230. Should we be doing foot checks? Guys, we've stopped doing our physical head-to-toe assessment. I walk in, and the patient's like, I have a wound over here. Quítate los zapatos. Take off your shoes. I want to see your toes. 9 times out of 10, they have fungus. Is onychomycosis of the nails, right? Is onychomycosis, fungus in the nails, is that an open wound? Yes, it's an open wound. Your patients are walking around with all of their toes completely open, and then you wonder, when you see those chronic cellulitis patients in your clinic, take off their shoes. You're like, is it PVD? Is it cellulitis? And they're on antibiotics forever. We need to look at the hemosiderin staining. You see the darkness around the legs? That's venous stasis, right? venous stasis, they're gonna ulcerate at any point. They need to have a full peripheral vascular disease assessment, right? And then you take off the shoes and they got fungus. I'm like, oh, you're a walking time bomb. Those people are amputations waiting to happen. And then they're insensate. They don't feel anything. Triple whammy. Okay? And throughout the world, because this is going to be worldwide, we're on YouTube, every 30 seconds a leg is amputated. I have a dream, like Martin Luther King says. And it's going to happen, I'm sure, because we're on our way. We're going to be giving conferences all over the world to help people heal those wounds out. And it's going to be very cheap because not everybody can afford a skin cell. While we love bioengineered, all of the awesome stuff that the United States brings to the table, and we want to make it available for patients, so we will always fight to give the patient the best they can afford and the best that the insurance can cover, because that's what you should be giving patients. The best to treat them. Not what makes you the most money, but what is the best to treat them. But if I walk in and you tell me, would you like me to give you a Mercedes treatment or just, get you in a cheap Uber? If it's me, I would like the Mercedes treatment. I always tell them, do you want to heal fast or do you want to heal slow? Your insurance is covering these procedures. These are expensive procedures. But $10,000, $15,000 is a lot cheaper than $1 million after you get treatment for years, all these meds, the pain and suffering, and they cut your leg off anyway. Right? And now you don't have a leg, and now you lost your leg, and now you're in rehab. And then you're going to see that also, here it is. Every 30 seconds, the leg's amputated. Okay, let's go to the next one. 50% of the people that lose one leg have a chance to lose the other one within a year. How would you like to be with no legs? Next. The cost is billions and billions of dollars. Acknowledgements next. Okay, non-viable tissue. Since we're already looking at this one, Amor, I want to see what Dr. Reyes has for his presentation. Para que de una vez, if we need more connections, we can get Dr. Reyes as well. Okay, non-viable tissue. Does this look like it's healing? Why do you say no to me now and you never say no to me when you see them in the clinic? And you never say no whenever you see them as a patient? And you keep slapping on the bedtime or the wet to dry? And you never have the heart to say, do you think you're healing? You don't have to say your doctor's not doing a good job. Never. Never. But there's surgeons and then there's surgeons. There's cardios and then there's cardios. There's podiatrists and then there's podiatrists. There's nurses and then there's nurses. There's some very bad nurses. Nurses are still the most trusted profession. But I've seen some very bad nurses that don't care about patients. And I call them out every time. Okay? We have to be patient advocates. However, we have to be patient advocates. If you're looking at this black, dry, hard, infected wound, can you please tell your patient that he needs a second opinion? If you don't tell your patient that he needs a second opinion, can you say, do you think you're healing? Si usted tiene esta herida, familia que nos está viendo, y si usted se está viendo su pie así negro y ya lleva semanas, es más, para mi gusto, a mí no me gusta que esté así ni días. Si está así con esta herida en días, usted necesita inmediatamente ver a otra persona porque no se está mejorando. Hay mucha gente que lo puede ver para esto. Esta herida no se está sanando. So this wound, this non-viable tissue has to be debrided. There's a lot of ways to do it. Please do take into consideration the patient's pain. I get paid more when I debride. But a lot of times when patients come in, do I cut them? Maybe? No, ma'am. I touch it. Okay, we're not going to debride you today. You're a candidate for what? Enzymatic debriding. You're probably also infected. No, I'm sending you to Dr. Farias and Reyes because this is surgical. You have to know also your scope of practice. I am not a surgeon. I am not a doctor. I am, however, a board-certified APRN with prescriptive authority with 4 board certs. I am that. And I will practice in that scope. And I will be a patient advocate. I can debride this. I will debride it. Probably next time there's patients. In this case, I'll do enzymatic debridement. We'll do mechanical debridement with our lovely hydroferroblue. I don't know any other product like hydroferroblue, so I talk about it because it's a darn good product and there's no booth here. So we put the enzymatic debridement cream, then we put your hydroferro on top, and it goes on wet, comes off dry. Every time it comes, what does it do, Lori? It pulls. It's already doing some debridement. So all my edges, within a week, by the time the patient comes back, all the edges of this necrotic, 9 times out of 10, if they're compliant, they're lifted. So all I do is get my scalpel, Lido, get my scalpel, just kind of cut around. It's like a lid, like a cap. Just kind of cut a little bit around, lift a little bit, cut off that little bit, continue the same treatment. Does it pay as much? No, it doesn't. We do get paid by square centimeter, sorry. We get paid by square centimeter of debridement. So I'd rather build a 99212 than build a debridement and hurt the patient. Also, if this is a limb, do you debride? No. Do you know the vascular status of the patient? You have to know the vascular status of the patient before you debride limbs, or they're going to get worse. If it's a dry foot, that's why doctors always like, okay, we need vascular first to check before we do debridements. Okay? So you have to remove that. Next. Inflammation, infection. Is this an infected wound? Absolutely. So that's another thing. If I go, I'm like, this is an infected wound. I'm clinically telling you it's infected. Do we swab this? No. You have to scrub all that, get it real clean. Matter of fact, my preference really is to start them on a wash. So I do Hebe Cleanse. It's cheap. It's a great surgical wash for the whole week. Something like this, I probably maybe use some Santo Hydrofera. And then next week when they come less inflamed with all the local flora already washed off, all the infection because it's infected, more than likely the cellulitis is somewhat improved. This is chronic. They've had it already for months or whatever. Then I do a punch biopsy and I send the actual tissue out. Then with that, you can prescribe an antibiotic. That's the best way to do it. Okay? Antibiotic stewardship is very important. Everybody's talking about antibiotic stewardship. We're here so everybody gets meds from across Mexico. What is it? We all love cephalexin. Cephalexin is doing nothing for people these days. Don't even write it. Just order Hebe Cleanse and send them to me if you don't know. Or send them on a punch biopsy. Wash it out with Hebe Cleanse, send a punch biopsy, treat them based on that punch biopsy a week later. So we go on to the next one. And I'm not going to steal Sandra's thunder because Ms. Flores is going to speak about infection and wound control. Edema. We already talked about this. Do we give Lasix to all the swelling? No, we don't give nurse practitioners Lasix to anybody with leg edema. Why? Because it could be a peripheral vascular disease venous stasis problem. It could be, if it's one-sided, it could be a DVT. But this wound's not going to heal because it's a swamp. It's too wet. Now, if you notice, the wound itself doesn't look like it's oozing out fluid. But the tissue around it has to be flat because wounds close from what? From the bottom up, from the outside in. Maybe he needs just a little bit of compression. We don't know. It depends on the case. Narrow the etiology, treat accordingly, med review, comorbidities. Maybe they need compression massage and vascular intervention. So we're not saying for you to massage your legs. None of this is medical advice. As me Lopez said to massage my leg. I said to go seek healthcare and somebody has to work you up. But we, as practitioners, maybe this is what we're going to treat with. Maybe. We go on to the next one. Vascular interventions for sure. Wound microenvironment. We have a mnemonic measure. Measure and measure. You have to measure every week. Length, width, depth. I always look for undermining. I look for all the rolling end, the epibole. I look for tunnels. Okay? And I look for bone, tendon, etc. Exudate. How much liquid is coming out of it? If it's wet, you dry it. If it's dry, you wet it. Appearance. The idea is this. You need to find something. What can I do with this patient's insurance to suck the fluid out? Like if it's too much fluid, that's it. It's always all wet around. I need to protect the periskin too, because then you get another wound. All of that logical stuff, right? Appearance. How does the wound look? There's patients that I'm measuring, and I'm like, there's no change in the measurement. It's weird. Minimal, hardly nothing. But I'm like, you're healing. Your surrounding skin is better, your edema is down, there's no more cellulitis, and your flesh around the wound looks like it's healing. There's an eye for that. That's why I have to see you. I can't treat you based on a picture. Suffering. Very important to address the suffering. I love salonpas. Is that a Filipino product? Then why do all my Filipino friends tell me, oh, prescribe salonpas or use salonpas? We use a lot of patches too in Mexico, but I hadn't heard of salonpas. I don't know how you would say that in English. Salonpas. You can't. Salonpas. Same. It works. So I've written this a lot ever since my hospital rounding time. We, and this is one of my standing orders, apply lidocaine patch as close to the wound as possible, surround the wound, 2 patches, 12 hours on, 12 hours off, away from the wound, but like not in the wound. I have to put away from the wound because then people have stuck it on the I'm like, oh, change that. I put as close to the wound as possible. And they put it on the wound. And then I said, as close to the wound as possible, away from the wound. And then it was a little bit clearer. So you have to treat the pain. I am big on stewardship I don't write tramadol, don't even think about it. I don't write tramadol, Tylenol with codeine for wound pain. I am so sorry. We are failing at being good stewards with controlled substances for our patients, and we have become legal prescribers of drugs, and the addiction rate is rampant. And I want you guys, if you have the pen, to understand the power and yet the responsibility you have with that pen to prescribe, the prescriptive authority pen. And then we look really bad as nurse practice if we're prescribing a ton of those without checking. Now we have new guidelines. We have to check on that website. You have to check if the patient's filling them somewhere else. And those of you that work with me and my patients know that I don't write narcotics. I don't write anxiolytics. The surgeons have to after surgery, they do it, but now it's getting less and less, right, doctor? Like how many days you give now with Tylenol with codeine or like anything like that, right after surgery? There you go. There you go. I don't have them either. They ask me for them and then they're like, can I have, I'm like, I don't have the setup on the computer. Now they require it to be, I don't know what, like double sided. You can't even do manual prescriptions anymore. You have to do the triptychal. But even like, we can't do those Schedule 3s, but before we used to be able to write manual tramadol number 30. I would always do number 30, no refills. So I guess what? I just tell the patient, I'm allowed to prescribe that, but I don't have access to prescribe it. I mean, if you have severe pain somewhere, I have to send you the pain. But I address the pain. Tylenol arthritis, offload. I tell them, if we heal your wound, you're not going to hurt anymore. I love gabapentin because a lot of it is diabetic neuropathy. I like gabapentin versus Lyrica because the Lyrica is controlled. So I'm like, I like gabapentin. Patients do really well with it. So undermining, you have to look at that patient's not going to heal if there's undermining. You have to fill the space. That's something very important. You got to fill the space with something. So always think about filling in space so it could grow in. And then you have to reevaluate. You look at the edges. They're not going to heal if the microenvironment isn't right. So next. Tissue growth optimized. Okay, once we have the tissue here, you can use bioengineered tissue. And we are very blessed to be able to do that in our company. We are one of the few providers that do house calls. There's so many products, right? We get 2-3 new vendors every day knocking on the door. Are you using this? Everybody wants to sell skin subs now. It has to be, then I'm real, like double-blinded, triple-blinded, quadruple-blinded, I'm just kidding. Controlled studies. I want a p-point of 0.000000001 if I'm going to pick your product, right? I don't like to post offensive things on the page, but there's a real funny meme that says, some of y'all have never had to make decisions based on double-blinded controlled studies, and it shows. And that is a peer-reviewed, double-blinded controlled study, peer-reviewed research, and it shows. If you're something as high-end as a bioengineered tissue, I have a lot of choices. I have to pick the best, and I have to pick the best for the patient that is covered. Because since they're high-end, they do a lot of audits on that. So we are crossing our eyes and dotting our T's. We're doing it backwards in our facility. We make sure all the documentation's in order and that the patient qualifies prior to doing this. But I will not deny a patient. A lot of people are scared to do it. I will not deny a patient a Mercedes level best available treatment for them to heal fast because I'm scared. We have lawyered up. We are ready to fight for the patient because sadly, there's always witch hunts because people are doing things wrong. But when you're doing things right, you got to give the patient the best possible treatment for that patient so they heal fast. So we do skin substitutes, we do bioengineered tissue. We are also doing house calls for wound care from Rio Grande City all the way to South Padre Island. And the patient can get the bioengineered tissue in their house based on if they qualify. In order to put it, the wound has to look like this. So this is the trick. Give me one like this. You guys never send me referrals that look like that. You send me what's hanging off and like, can I have an easy one? The skill and the teamwork it takes to get them to here. Here, I always tell my patients, once I graduate you to a powder, you're almost there. But a lot of times we have how do you get a patient from the black? Did everybody get these? We're gonna go through more. These are our brochures. These are just some of our wounds that have gone through our clinic. And I was telling my fiance, Marco, they go, Amor, we have to make more already. We have so many more, but I'm lazy because I'm the one that does it. I have a lot of fun doing it. And then I post them on Facebook, and then the patient, and then the Facebook blocks me. You're posting offensive images, and it's we covered your photo, which I'm okay, because then I feel like, well, like they said about the channel, I have to have drama. So I need to slap some people here to get more viewers. And people like what's covered up because they want to see what's behind the picture. Okay. So, once the patient, negative wound pressure. Guys, I don't have the back people here, but I've had them in our conference before. Again, I don't even reach out because I told everybody about this 4 weeks ago. So all the people that showed up in the vendors, thank you. I love wound vacs. They're good. And they're wound vacs, and then there's wound vacs. Wound vac is a proprietary. Negative pressure wound therapy is a beautiful thing. You put a sponge in the wound bed. It's completely covered. It's attached to suction. There's different modes. Intensity, low, high intensity, the amount of suction. I usually like 125 mmHg, high intensity continuous, but you can modify it if the patient's in pain based on exudate. Sometimes it's too way, we have to go a little higher to 150. I am a VAC nurse. I have VAC patients in a house, alone, with no assistance, with no aircon, with dogs and feces and cats, with no light. God's hearing me. With no light, on an obese kid between the rectum and the scrotum. Have you ever backed that one? With no help. I sat, what the F is right? I sat on the floor, and the kid laid down on his mattress, which that's what he had for a bed. And he would always come in from riding his bike. Imagine how I would feel. Watching him come in riding his bike, and I was like, you kid, you're making me go through all this. You're not going to heal like el amiguito. Remember you came right to? I'm not going to back you. He healed out. But then he reopened. What do you think it was? If he healed out there, it was a tough one. But I'm going to tell you, I can back anything with my eyes closed. Anything after backing him. And then remember the stoma paste? I always had to stoma paste him at the end because that was always a little, if you've never heard, and then, you haven't lived. You're not a nurse. You've heard that. If I go, what do you think? Freaking wound vac has a leak. So now I gotta stoma paste it, right? I love stoma paste. I would just stoma paste the heck out of that. And if you've never used stoma paste, you haven't lived, because you gotta do it a certain way, or it's everywhere. I'm like, so you have to do it fast. Do it fast before it gets hard, and then it gets real hard, like caulking. So we vac that kid. Why did it open? Fistula. We vac the fistula. I told the surgeon, I said, I think this is a fistula. You think, yeah. Well, it's healing. Let me try. It just looks weird, And it closed. Did he develop a fistula later? I don't know. Remember, once a wound's been open for a certain amount of time, the body thinks it's a natural orifice. It's my hole. I want it. Give me my hole. That's why I can't lose weight. Did you know? This is a new study, so don't feel so bad. If you've been in a certain weight for a certain amount of time, your body thinks this is my homeostasis. So in order for you to keep weight off, you have to get to the weight you want and stay there for a minimum of 6 months. This is a study that just came out, which most of us can stay thin for like 2-3 months, and then you slowly, and you're like, why is it? We talked about this with Kyle. Why is it that my body's stuck at 165? And before I used to, and I gain and I lose, and I never go below 165. Because my body likes 165 and it wants to stay there. It's comfortable there, but my knees don't like it. So back to this. I digress, but it's a lot of pearls. So body's trying to stay in homeostasis. That's why you get a fistula, pearl. Think about if it's a fistula before you vac it. Usually you know, because there's a different kind of discharge. And what's a fistula? Just an orifice, right, doc? That goes from under. Do they usually get better if you fix them surgically, or they come back? Fistulas. Exactly. Loaded $1 million question. So, but they're nasty, right? They're hard to deal with. They're bothersome because it's hard to close them. And okay. Hyperbaric oxygen therapy. We do refer to providers who provide hyperbaric oxygen therapy. I used to always refer to Dr. Farias, but he's not doing it still, right? So I have another thing that's doing hyperbarics. We refer wherever they need to go. And honestly, I've had patients like you. You're not kidding with me. I refer patients to Dr. Marisol de la Garza in surgery, Aide, specifically. I would say I refer them to Aide because she does all that. She's a nurse practitioner. She's my nurse practitioner. So, learn to refer out. Let's be humble enough to refer out. So we go to the next one. Next one. This is one of our patients, and here we go with all the ones. I love these. This is one of our patients. It's really hard to treat a pressure ulcer in the coccyx. Usually when I see, back when I was a nurse, a floor nurse, I would see a pressure ulcer in the coccyx. I'm like, that's it. The patient's dying. If I would see that, I was like, that's it. This is not going to heal, and it's going to go to the bone, and they're going to die. And then I would get so worried because the surgeon would take them for debridement, and I would think, God, they're going to mess them up more. Now I see a bone. And not all of them use bags. So some of them would say wet to dry after. And I'm like, oh my gosh, because of course you can't use them all the time. So this is one of our patients. He healed out. We did enzymatic debridement. We did a lot of offloading. You're not going to believe the main treatment for this patient that we did. Zinc oxide, 40%, 20 times a day. I would get calls on that one. Why are you writing orders like this? It's cost the facility a lot of money. We can't put zinc oxide 20 times a day. Is it okay? 10 times in PRN if the coccygeal area and the wound are not completely white. Thank you. Can you bring it down to 5? Absolutely not. The patient healed out. I did do some debridement, I did do some enzymatic, but nothing stays in the coccyx. Nothing stays in a coccyx wound. It all falls off. Not zinc oxide. Remember, to me, zinc oxide is a primary dressing, depending on the site. Is it not? Have you seen how thick that thing is? Okay. So, hard to get off, so that's why I would tell them. This is the other thing. When you have a coccyx wound or you have a gluteal wound, I always tell them, don't scrub them more. Like every time they pee, wound cleanser, like you're taking off all the new tissue. So I would just tell them, pat dry, wash them, give them their bath once a day with the soap and water, pat dry, and then put a lot more zinc oxide. It's not infected, guys. I say, put more on. And when I would round, if I would turn them and they were not thick and white, I'd tell them, that's not putting it on, and I would write the same wound again, wound care order. Don't get me wrong, guys. I'm a business person. Zinc oxide is dirt cheap. It's not like I'm ordering some very expensive cream 20 times a day. Is that a little off? Yeah. Is there evidence-based, Ms. Lopez? There's my evidence right here. I have enough sense to know that works, so I love that. I love that for patients. And every time I have a gluteal or coccyx wound, I tell the family. I do now only outpatient. I already withdrew privileges from the hospital. And I'm glad I did because we're so busy, man. We would round. We'd see patients in the clinic, and then we'd go around at the hospital, and we'd go around in the nursing home. And that was a lot. One day I took out 365 days in the LTAC. And I had my clinic. And then when I was hospitalized, I said, this is for the birds. You got to pour into yourself too. That's a thing. If you're not filling your cup, you have to surround yourself as people, as nurses, as clinicians, as doctors, with people that fill you back. You have to surround yourself with people that have you, that have your back. You have to. I love Dr. Michael's journey. I've been watching him just so lean. Who have you been focusing on, doctor, the last? Who? You. I have been focusing on me probably for the last 5 years, and I love it. Finally, before I focus on are my kids okay? Is my mom okay? Everybody, my grandma, how's everybody? Just everybody okay? I want to lift everybody up. Nurses do that. That's part of this health and wellness. Our show is called Health, Balance, and Wellness with April Lopez. It talks about balance and wellness. We caregivers, practitioners, that's why sometimes you have to turn your phone off. I learned this. A mí me decían, some of my colleagues, Dr. Quintana, I love you, Dr. Quintana, God bless you. He's one of my mentors. We used to do wound care together at the hospitals, and he does a lot of PVD work. He still does a lot of PVD work for us. We have providers that we work with we still send patients that way. We send patients to the HR. I have no affiliations with anyone. I have affiliations with Dr. Jose Farias. I have affiliation with Dr. Luis Reyes. What's my affiliation? Trust, respect, and a long-term friendship of him doing a good job for my patient. Not of him being my buddy. He does a good job. When I send him a patient, he respects their wishes. Sometimes I'm like, Doc, I see a foot. This patient needs to lose a leg. Ya vienen. Like sometimes they come, I could smell them from the hallway. Have you ever smelled a wound from the hallway? I walk in, the bone's sticking out. It's blue-green. What's blue-green? What's blue-green? Pseudomonas. Good old Pseudomonas. You'll never forget it. Excuse me, we have this machine called the Moleculite. We take pictures of the wounds. It's amazing. It even diagnoses abscesses. I diagnose it, but it showed me there's an abscess under, and I'm like, surgical. It's a modality that we have in the clinic. And it tells you that if you see the green light, I'm looking at the wound, this is infected. But blue-green is Pseudomonas, right? So I walk in the room, and the person's like, I'm here because I know you can help me heal. And I've seen the videos, and you can heal. And I'm like, I know that patient needs an amputation. Needs to go to the hospital. I want to have you handle wound. I don't want to crush the spirits of the patient. I am very empathetic as a nurse. I want to hold up the world. That's why I have a back injury. One of my patients almost fell. I was a brand new teeny nurse. I was going to save him, and he was ready to be, I pulled something, and later present the preview. That's it. My health pain gone. But it's healed in the name of Jesus. I'm doing therapy for it, and I'm exercising. It is getting better. So I don't want to tell the patient, you need an amputation. This is the first visit. I'm going to crush his spirit. He's looking at me hopeful. And I'm like, okay, what have they told you before? Like, throw it on the other guy. Whatever they're... And he's like, no, pues they want to cut it off. I'm like, okay. Do you know why they want to do the amputation? There's times when they need it, guys. That's why we're trying to get this information out to you guys. Do the next one. We want you to get to us before they're at that point. And he goes, well, they're saying that, my bone's infected. I said, okay. Can you smell it? Yes. Does it smell good? See, it's not that hard. Does it smell good? No. Okay. I'm looking at it, take a picture of it. Sometimes your patient can't see. Do we understand that sometimes patients cannot see their wound? So we have to remember that. Sometimes the patient's legally blind. He could see you, so he acts like he could see you, but he really can't see the wound. He just sees shadows. So, can you see me okay? No, I can't. Okay. He can't see me. No, he can't. Okay. Can you see it? There's a family member there. That's the wife. I know you can heal. You helped his brother. Okay. So can you see? Yes. How does it look? Black. Okay, it's black. Okay, sir, your wound is black. I see the bone. There is blue-green. I smell it. How do you feel? Usually these patients are septic. He's like, you don't feel good. So I'm going to tell you the only time that I recommend an amputation. I have taken care of patients that walk in with a black, dry 2 toes, and they walk in with their regular shoes, and then we put them on the bed and we take off the stuff, and there are the 2, 3 black toes, and I'm looking at him, and then he's like, I don't want to amputate these. He's 60 years old, still smoking. He feels good. I'm sure his hemoglobin A1C is 16, but he feels good. He drinks, he smokes. I'm good. I'm strong. I don't want these amputated. That patient doesn't need those amputation stats, but that patient needs a workup. So I always ask, would you like to go to the hospital for your workup so it's faster? We can admit you. I'll call a hospitalist group. They'll see you. They call my peripheral vascular disease specialist. They'll call my surgeon. Okay, surgeon, no, hold on. Your toes are black, dry, and hard. I cannot guarantee that they'll come back. We know they're not going to come back, right, Dr. Farias? But sometimes I call them and I'm like, this patient wants his tooth down. Let me see him. But we're going to end up with an amputation on that. Now, I'm going to tell you, if you have a tip that's black, we're going to fight for it. Dr. Reyes, I don't know where you went, but Dr. Reyes will be like, I just did half of the tip. You can't pay for that, guys. What are you giving that man? I have a man. There's a lot of patients that I was going to invite to give testimonies, but they're quite sick and tired and frail, and I know that they would come if I told them to come, but I don't want to bother them. And we've always had testimonies because it was so short notice again. But there's a man that I've treated twice, and I'll never forget that story, and we're going to see that. Matter of fact, let me see if we can go forward to his wound. He was a young man. What do you think is young? What do you guys consider young? Oh, that's right, baby girl. I consider young. I consider young. 70 years too young to me, because I'm almost 50. So I see some 70-year-old men that are they're still working. Dr. Sharif Yomi, I don't even know how old he is, but he ran up and down the stairs last time I went with him. Age is really truly a number, and it's based on what? Your health, your wellness, your health status, where you're at, what you do. Really, who you're with, who you spend time with, who you share your energy with. That's why I'm going to marry Marco, because he's a little bit younger than me. So this particular patient walks into my office, and he was in a wheelchair, and he was like this slouched over, wore a cap, and he comes into my office, and he's like, Ms. Lopez, the top one on the far right, it's your far up left corner. He's Ms. Lopez. I've had this wound on my foot already for 8 months, and I'm staring at the drain, Dr. Right? So like, you had this draining for 8 months? He's like, yeah, you're right. He's like, yes. Who's your surgeon? Somebody in Rio Grande City. Not in Rio Grande City, Johnny. Johnny was supposed to be Rio. He's from Rio. Meme, not in Rio. Meme has a ranch in Rio. Goes and shoots palomas. Who's your surgeon? Oh, Dr. Schwartz. Has he explained to you why you need to drain? Well, he says because it's draining. Well, it's going to keep draining with the draining for 8 months. Believe me, it's a foreign body. The body can't close with that, right? It was just poor care. So that right there and then I just took that drain out. I said, Of course, I sent him to the surgeon, as you see, for a second opinion. I don't know if this is your case, because you're the only one I sent to. He went for a second opinion. He got debrided, and I needed that open. And sometimes they don't want that. They're like, no, but how are you going to make a bigger hole? And sometimes you need to make a bigger hole to close a hole. So I hate those tiny wounds that are 1 by 1 by 17. Gee, what do you do with that wound? You can't back it. You can't pack it forever, right? I love to do powder and packing. We have an awesome powder that we use. And it depends on the case. There's different ones that we use. They're prescribed. And I literally pack with a powder and then pack with a packing strip. Come in, sweetheart. Come in, queen. And so pack with a powder and pack with a packing strip. Miss Flores, if you would like, you could sit right here in the VIP table. You want to help Miss Flores, sweetheart? She just walked in. Come in, princess. This is Miss Sandra Flores, my good friend and colleague. You want to sit there or here, Miss Flores? Wherever you want. Okay. I love you. I always introduce people. It's in my show. You're coming out of my show number. So this particular patient, back to this patient, what do you do for that deep wound though? Back to that. I have a patient probably watching right now. I love you. She had a surgery, a plastic surgery. Guys, can we please stop going to Mexico for plastic surgeries? Familia, yo adoro a México, soy mexicana. Pero, híjole, hay mucha infección. Se está muriendo la gente de meningitis. Una influencer, pobrecita, Dios la bendiga, murió con sus niños bien chiquitos. La niña tenía 29 años, no sé cuántos años. Me llegan todos mal acomodados de otros países con heridas infectadas. No vayan a otras partes, no se hagan eso, mejor déjense ahí la pancita. Porque se mueren, te mueres, prefieres morirte. Eso es una enfermedad, Let's talk about that. Some of us need some therapy because I get some patients and I'm like, well, how many surgeries have you? This is already my 4th one. What did you do? I did my thighs. You're so beautiful. You did your thighs and now you have a wound and that took forever, but it heals. What do you do for those? You have to rule out infection. You have to make sure I know what to do because, a lot of times the patients are colonized. Our normal staph flora. Now people have MRSA on this. There's MRSA in the community. We don't get scared anymore. There's all these bugs. So we decolonize the patient. Okay, what time is it? What time is it? From neck to toe. What? 10:48. 10:48. From neck to toe. DB cleanse. Decolonize that patient. I don't care. I throw everything at it. Because there is no evidence-based data for that. Nobody's doing research on wounds. That's one of the things I'm going to do. I'm not going to get a doctorate in that because I'm going to get a JD. But I'd rather spend my time in law school than that. But I want to do research on wound care. I'm gonna do it. I have to do it. It is a must. So people follow a guideline that is on natural research, double-blinded study, published, so people can help people heal. But I had her wash the whole body from neck to toe with Hebe Cleanse every day to decolonize it for 7 days. By the way, there's evidence base for that. A lot of surgeons like to do those washes for their patients, and there are some studies that show that it helps decrease infection. If he wants to do it, why can't I? So then we did, of course, we irrigated, we packed, we put powder in there. And I think it was just that she wasn't packing deep enough because she was scared, because really the Q-tip couldn't go in. So I really feel like it was longer than 17. Like it just, the Q-tip couldn't go in to pack her right. So I was like, just make a real super long strip and pack it from here as much as you can. It's eventually gonna pack in there. Even if you can't push it all the way in, it's gonna stack till it comes out. And that's just clinical expertise and trial and error, just trying to help the patient. So this patient came in like this, sitting, talking about breaking spirits. And little by little, you started seeing him sit up a little more, light up a little more. That's right, you're watching, light up a little more. And then he's here. And then little by little, one day he came, he wasn't supposed to be on it, but he had an off-roading shoe on. I didn't say to walk. Can you heal with walking on a wound? You can't. If you squish your foot, you're going to squish all the cells that you just created. I don't care if it's one time. You got to stay off and you have to go to the bathroom like this. I'm not saying not to move. Mobility is very important because then you get atrophy. That's the other thing. So you're not just like this with your foot. You are with your foot, with your knee, offloaded. Like me, I had to learn. It was so difficult for me. Go to the gym, hardcore. Let's do some jogging. Let's do some elliptical. Let's lift heavy, 25 pounders. You know, everything. You want to do 100. I did 160 on the legs. I'm not that heavy. But then I would do 110 pounds on my inner and outer. I have a torn piriformis. I should have never been doing that much weight. Of course, I'm going to mess up my knee and everything else. So what do now? I don't do more than 5 to 10 pounds of weight. But I will do all the way to burn, all the way to where it's exhaustion. What do you call it? So I'll do like 30 because I don't feel anything because I'm used to lifting. So it's okay. Form versus weight. If I do this with 5 pounders for 40 times till I find it takes me like 30 to feel a burn. And I feel like I'm not doing anything. My mind is telling me that I should be lifting 20 pounds and I'm okay. I wouldn't do 20 here, so I would do 20 and 25s here. I would do deadlifts, 160. And my low back, I'm killing my low back. I have L spine issues. Like, this is why I say it's a mental issue. You have to, and then Dr. Michael comes and tells me, are you competing? Are you going to compete? I'm like, no. He goes, so you're working out for health. There's people that shape you throughout your life and you may not even know that you're shaping people. There's people that have influenced my practice, and they don't even know that they've influenced my practice. Robert is one of those people. Lynn is one of those people. She told me, I walked into the room of the patient, and I'm like, I come on in, Lynn. I was on your nurse. I can't start the IV on that patient. Lynn, I love you, Lynn. Oh my goodness, April, she's sleeping. From the 3rd floor telly at Edinburgh. Oh my God, is the patient dead? I go, no. She goes, then get in there and find a vein because the patient's alive and you can't start an IV and I'm not going to start it for you. I could still hear her. And then I thought, oh, it's me and me. I could tell my daughter, it's you and God. It's you and God. You don't need mom, you don't need dad, you don't need a man, you don't need a friend. For children, their developmental level, they need a lot of support. They need friends and everything. But they get hurt. Their little best friend hurts them. And I tell her, you cry out to God because it's you and God. As a nurse, it's you and you, especially if you're doing home health. Because when you have an IV due in home health, you have 6 other, 8 other, 10 other patients. If the line comes out, you have to start it. It's you and you. So learn that early on. So then this patient comes in, and then he comes in walking, and I said, how tall are you? I always thought he was a short man, a short, frail, older man. He's like, is he 6'4"? I think he's like, I'm 6'4". I'm like, I would always call him coach because I thought he was a coach and he's not, he's a history teacher. But I'm like, coach, you're 6'4". never underestimate the power of that positivity and the good vibes and the faith in a patient's outcome. Because this patient, yes, he was healing, but this patient felt good and joyous because he had hope. And every time he came in, I would tell him, look at me, you're gonna heal. We have a lady that always posts on our pages, and she's like our best promoter. She tells everybody what she has, and I have these wounds, and she's helping me. And depending on the patient, they may not be so positive because they've had these wounds for years. So when you come in, like, yeah, what are you gonna do for me? No, you know, they've already done this, and I'm not healing and everything. No, you're gonna heal. I'm gonna do my best. Primero Dios, God first. I expect you to heal. I expect you to heal. I expect every patient to heal. Sometimes patients end up with toes amputated, sometimes they have TMA, sometimes they have surgical debridement, sometimes they have an amputation. But I tell them, I want to save your life, not your leg. At that point, I'm already there. I have to say that. That is what it is. I want you to live. But from now on, this is where our head to toe assessment is so important. Please check the feet. I tell them, take off your shoes. Check the other foot. You have one piecito. We gotta heal you fast. We gotta heal you fast. The name of the game is to heal you fast. So when you come in, I'm gonna order everything. I'm gonna order an ABI. I'm gonna order this. I'm gonna order that. I'm gonna do a full workup. I want your labs for your PCP. I wanna see your blood work. I'm gonna, order home health so you can have a nurse to follow. They come and they have 2 or 3 of the same meds. They have unfinished antibiotics. They're not doing compression right. They're not doing wound care right. It's so hard. Nurses are the heart of healthcare. They need that TLC, that education. So this patient ended up being so tall, and I never knew, but it was because he was not healing and he was sad. So we did all this, we were here, and here, this lady. This lady healed out, she had a TMA, and she passed with her leg on, from what I know, and she never quit smoking. Guys, we can't smoke. I said way early in the conference, I'm an ER night nurse. I smoked and drank coffee for a long time. We have to quit smoking because it kills your legs. You will end up with an amputation. There's nothing I can do for you because how tiny is the arteries in the toes? Like a hairline.
That's what it's called, microvascular.
Microvascular. I can't do anything for your little toe, and the gangrene can go up, right? If you have bad surgery in the toe, so don't smoke. I have to say it. I sound like a hypocrite. I'm smoking more. Praise be to God. Okay, so this lady, of course, we did enzymatic debridements, we did mechanical debridements, we did sharp debridements, and she passed with her piernita. She healed out her TMA. Next. And this is a gentleman, this is a diabetic gentleman, and every time I put up a case, I remember the issues we had to address. His sugar was always 600, super, super high, very, very young, walking on the foot like this. As you can see, you see tendon, right? And you could see at the bottom that there's another opening. So we could stick a Q-tip right through. So sometimes people don't show them that, so I go, look, let me show you something. And I stick the Q-tip right through, and he looks like, oh, I didn't know I had that. I'm like, oh, okay. Nobody's putting a Q-tip in to see. So I go, you have a wound on the bottom, and you have a wound on the top, because there's a complete hole right through your foot. So of course the offloading, I love, Amazon's my best friend. Like if you're ever looking for some gadget, just put in there. Offloading thing for knee with no foot pressure, and it'll show you everything. I love it. So he had to get on one of those little scooter things where you put your knee on. It's completely offloading the foot. Because guys, an offloading shoe is not enough to offload the foot. They'll step on it. And they probably, in the offloading shoe, there's a high risk for falls. So they hate wearing it. So I tell them, just use one of these. It's really for ankle injuries, but I use them for that. He healed out completely. I told him one other thing. If you don't control your sugar, you're not going to heal. Is that clear? What do you mean? One of our patients, I sent her to HBO. The MRI wasn't covered. We also have to face that. We treat patients based on what they need. Based on their insurance, like I have patients that still need MRIs that can't get them. It doesn't cover. They can't afford it. But the same patient drinks 10 Cokes a day. I'm not lying. There's still people that drink 10 Cokes a day with sugar, and they're diabetic. I don't judge, because I have been 260 pounds at one point, and I have food addictions. I have a hard time. I love eating. I'm Mexican. Our plates, my grandma would serve us like this. It was a serving for 3 to 4 people. We don't throw food away. That all comes from the disparities. We didn't know when we were going to eat again, right? We were not dirt poor, but in my grandma's mentality, she was a lot worse off than we were. In her mentality, I feed you a lot because I want you to eat a lot. Because right now I have it and I want you to eat a lot. We don't understand that this is why those things are. We have to understand it. Because she grew up in a place where there wasn't an abundance. Right? And some of the stories she tells me, no digas que nosotros pasamos por eso. But very, very poor settings. So you had good food, you got served a lot, in her mind. Our generation wasn't like that, but we eat too much. When we cook it, this is my beautiful mom, Angie, Maria de los Angeles, de Serra. Let's clap for my mama. Because she carried me in her womb. Now that I have to go, thank you for carrying me in your womb. So, ya se me fue la onda because I love you. So, health disparities. So, if a patient is eating, whenever you cook, I had to learn this. I like to cook 2 cups of rice. Why am I cooking 2 cups of rice? Because I always saw them cook 2 to 3 cups of rice because we make a lot of rice because we eat a lot. And there's usually a lot of people, but we also eat a lot and we always serve seconds, right? So this patient's sugar was real high and I told him, you have to cut your sugar. You have to control your hemoglobin A1C or I cannot help you. You will not heal. I can throw the best treatment at you. You'll never heal. He listened. If you comply, you get better. I always tell my patients, if you listen to me, you get better. So next. And this is another patient. He loved to be barefoot. I like to be barefoot. I put up a video yesterday. I don't care if it's dirty. I like to be barefoot. I feel grounded. There's a grounding thing that people do on dirt and grass. I used to do it a lot before pandemic, then I stopped, and last night I just took off my shoes and I was walking around barefoot. You can't be barefoot if you're a diabetic and you're insensate. You don't feel? He walked around barefoot, but outside. Like he'd walk to places. I think he had a psych issue too, but it wasn't very evident. It's one of those psych patients that barely fall through the cracks. He didn't have family. He had family, but not a lot of support. So he would walk around barefoot, but all his feet were bad. This is just one of the wounds. He healed out. We have to remove that yellow. Is that wound going to heal with all that fibrin? No, it's not. Fibrin, slough. Then we have to, that wound looks a little wetter. Does that wound look a little wet or a little dry to you? They're wet. So what do you do with that wound? You got it. That's all I want you to take away from the conference. That's all I want you to take away. Next, you got it. There's still people who don't get it. They'll throw some ointment on the wound. Offloading. This is not proper offloading. That's why the pictures are. That's not offloading. It's a spongy sponge. The patient's gonna step and put pressure, but we used to do that. Hey, we've done stuff as nurses, whatever we can do to help offload the patient. We haven't always had offloading shoes. Sometimes the patients don't qualify for an offloading shoe, right? They're expensive. They're like $70. They won't heal. I always tell them, understand me this. If you step 2 times on my wound, you're not healing. And then they come back, you always know when they're putting pressure because what is surrounding the wound? Callus. And they're like, how do you know that I am walking? I'm like, I'm looking at the callo all around me, so that would be putting pressure. Can you cut the callo? No, I'm not going to cut the callo. I'm going to see how you do, and let me see if you're going to offload. And then they come next week, it's so soft. It's so soft. And they'll start healing. But not if they step on. I don't care what it is. Now, let's think about wounds in another part of the body. The previous patient that healed with a coccygeal wound that you saw black and then you saw healed, that was in the butt part. Do you think we have to offload? Yes, you have to offload. You have to offload anything. If the wound is here, you have to offload that. If the wound is here, you have to offload that. Some people are like, I don't know why I don't heal. Well, where do you sleep? On my stomach. Like, all night long, you're on the wound. You're so right. These are like common sense things that you just gotta talk to the patient about, right? That's the report. So next. You have to do good pain control, being a good steward with your prescriptive authority. I already talked to you about the Lido, topical Lido. If it's mucous membrane, it has to be mucous membrane jelly. The salompas or the lidocaine patches. It's just aspartame patches. Sometimes we'll cut them. You have to get real creative. I have a lady. I love these patients. They come in, and I'm like, I give them Lido. The lighters on back order right now, there's a shortage. I have so much. I give them Salon Pass or I give them Lido Patch. She's allergic. She comes back with a rash. I can't give. She can't have Tylenol, regular Tylenol. She has a liver issue. And I don't like NSAIDs because they cause GI bleeds. And so what am I going to do for this patient? What am I going to do for this patient for pain control? Gabapentin. Because she does have, it's a periphery. It is diabetic neuropathy. But it is such a challenge for the pain control. You have to think it's not always, I don't ever get easy patients. I get like everything wrong with them. So we go next. Optimizing the host factors. This is very important. The patient is a whole patient. We understand that we get taught that from day one in nursing school. We are holistic. We have a holistic approach. So you have to assess the nutrition. High protein, high protein, high protein, high protein. And then your patient has kidney issues. He can't have high protein or whatever it is that he has. I like ProMod, 30 mLs twice a day. It's expensive. So I just tell them high protein, a lot of eggs. A lot of the patients hate meat now in their older age. I'm already there. I'm like, if it's not a Wagyu steak, don't give me carne because I have to bite it and chew it. I like fajita real well seasoned, but soft. No, like I can't just have meat like that because I'm like chewing forever and it hits hard on the stomach. I love eggs. Give them huevito with everything. Don't put them in a diet, guys. If you have your patients that are like, if all they can eat is chorizo con huevo because that's what they like and they have a wound, give them chorizo con huevo. Take away the flour tortillas and the rice and the potato. You have to. I have patients that are so cachexic and they're so skinny and their wounds are healing. And I'm looking at the patient and they're like, ¿Qué come? What do you eat? And the daughter, oh no, he's diabetic. I don't give him, you're doing a good job, daughters, you're doing a good job. But father already lost 80 pounds. Father is not 220 pounds now. Father is now 150. Father is now 80. He's no longer 70. And he's frail and he has a wound. Therefore, no, pues no me gusta. I don't like the food that they give me. They give me everything dry. And then, okay, what do you want to eat? I want to eat barbacoa. Take them to eat barbacoa with corn tortillas. This is where, don't kill me for saying to eat barbacoa. I'm talking about a special case. I don't eat barbacoa. I'm talking about a special case of a cachectic elderly man with diabetes who's not healing a wound, and the patient has no food in him. The other thing I love to buy are those high protein insures or high protein lucernas if they're diabetics, or even the Atkins. Sometimes those shakes are more expensive than the Atkins ones. The only thing I tell them, the Atkins ones don't have enough carbs. These ones have more nutrition. So give them 2 shakes, because that's 30 grams of protein, along with like a peanut butter sandwich or something, like with more food. And he needs a little bit of carbs too, some fruit. So I love those shakes, and I tell them, your shakes are not your meal replacement. Your shake in addition to. So in the morning, what do you want to eat? Chorizo con huevo with a little bit of black beans and 1 corn tortilla. And your shake, it's a chocolate. So that's your drink. So here, you already loaded him with some protein. He's probably only going to take a few bites of the egg, but he's going to finish the shake. I always do the test in my office. I always have that. I'm like, are you hungry? You want to taste it? Like, yeah. They finish it right there, and then the girl's like, usually the families are like, he drank it all. That's like, well, that's already 15 minutes. I'm like, they don't eat. At that age, you don't want to eat. You become like a child again. They just remember how the kids used to graze. So you gotta have snacks for them, high protein snacks for them to graze, and the shakes are amazing. So you have to look at the nutrition, the diabetes. We always look at the albumin. We have to look at the albumin. You have to control the diabetes. I always get the labs from the PCPs. Guys, I would always think logically. When I worked in the ICU, everybody would order labs, right? I would order labs as primary, and then ID would come and order labs, and then surgery would come and order labs, and then somebody else would come and order labs, and then the patient. And you know what I would think in my head? They're sucking the patient dry. I think these are too many tubes. This cannot be good for the patient. Then I read a study that said that there is an anemia related to too much blood drawing. There's an actual diagnosis to that. I said, aha, I knew it. That's why I tell you, like, you haven't read all the studies that are out there. But logically, does it make sense that you don't want to be drawing the patient 4 times, like, and every day, in the LTechs, I know they would draw, and then I would bump down, like, don't draw the labs every day. Draw the labs every 2-3 days. And then somebody else would come and order the labs, which we need the labs, don't get me wrong. I'm just saying you have to think about that too. So then, what are we gonna do? Are we gonna have to go by the thing? Okay. So then, we looked at, what about mobility? We're gonna talk about mobility in a little bit. Other systemic disease and psychosocial issues, and intervene. Do psychosocial issues matter?
No hay corriente ahí.
If your patient's depressed, is he going to get better? Right? You have to address it. And you have to intervene. You have to intervene. There's support groups too. Patients need that. I'm going to go back to the psychosocial right there. So the psychosocial, when a patient, like for example, procedures, I really feel like we need to have a psychosocial assessment prior to having so many procedures done. Is that a thing, Amy? Do you send your patients to psychosocial ideas of surgery? Some of them? Some don't meet criteria. What do you usually use as a baseline?
¿Por qué no lo mandan?
Pues es que no dejan mandarlo por correo porque...
¿Por qué?
Como es Mac, no está jalando un server para mandar.
And then it comes back.
El correo.
Because we're living.
Mandarlo y no se manda. Que porque está un error en el server.
Yeah. So I feel like we need to think about the psychosocial more guys out there. If you keep getting procedures and procedures and procedures,
Pero tiene el HDMI.
you cannot
No, el conector de
continue. You
corriente.
have to get some
Cuando tiene
psychosocial
batería.
help. We talked about
El
that.
doctor dice que ya fue. Si quieres, yo no.
Yo estamos viendo
Yo puedo ir si quieres.
Sí.
un ratito. No duran tanto.
Guys, that's one thing. I waited 2 years. I got my tummy tuck with Dr. Mauricio Lagarza. And I waited almost 2 years for him to be able to see my actual surgery. I'm okay waiting because I've treated too many wounds that are not healing. And I don't know what it is. They always make them too short. Like, leave more skin, surgeons. Déjenle más pila a los pacientes. Siempre es eso lo que es.
They do a lot of lipo in the big section of the area, and they're not supposed to do that much lipo.
That's what happens. Okay, they're doing too much lipo in an area of a tummy tuck, and they're not supposed to do that much, or else you have necrosis. Okay. So that's why I'm dealing with all these wounds. That makes sense.
But most of them need 2 rounds or 3 rounds, depending on how big they are prior to getting their surgery.
Of lipo. My status. Yeah. They do everything at once, right? That's the problem. Yeah, because they're saving money. Guys, it's so high risk that we are talking about wounds, but we're talking about life. I mean, I had a tummy tuck because I had everything hanging. But I had a cardiac workup. I had I had everything done. You know, I was so careful. I was down for 3 months. I did everything. So, okay, we continue. So we are in next. Now we're just going to look at wounds. These are wounds. All of these are wounds. Diabetic foot ulcer. Next. You see the tendon and all that? This is a knee. We had to actually remove the knee. And we had to, we vac this patient a lot. And then we used some powders. We did a lot of packing. And he's healed out. Next. And then this is a toe. This is a funny story. If you have to touch the skin, you have to touch the patient. Right? This was a patient in the hospital getting ready to have a toe amputation. The one on the left. I go. I said, Okay, let me debride it. PVD was fine, the circulation was fine. I
la
go, signs of debridement
Es la
consent.
presentación.
I
Y
go
las
with my
dos en la
hand
cámara que.
and I literally feel it. I have my scalpel and I go like this
Vean, le voy a ayudar.
and take off a callo that came off with no surgical debridement. That's what was under the toe.
Es otro doctor.
Ah, ok.
Did anybody touch that toe? Yeah, touch it. Oh, next. This is crazy, but it happened. Next. Okay, this needed a wound vac, right? This was a crush injury. We vacced him, then we did some powders, offloading, etc. But he was gonna have an amputation because it looked like that, and they just wanted to amputate. So we want, and he did have osteo. We understand that. We want to say that, guys. Hey, I'm not judging anybody who gets an amputation. I'm not judging anybody. People need amputations a lot of times, right? That's why we have surgeons. That's why there's a T-card procedure available, but sometimes patients need an endarterectomy, they need a full surgeon, and that's it's great that they have a surgeon there. We need to defer to the people that can do the work. And then this, you see the bone over there? There's a bone over there. You see it up there? That yellowish thing you see, that's bone, right? Think about it logically. If there's a bone under the thing, is there gonna be a bone there? Yes, the continuing of the bone. So if you're looking at a bone, that patient needs the ID, right? The MRI. That patient healed up. Next, this was my botas patient. He was always in botas. I go, you're not gonna heal with botas. Guys, if we cannot open the PowerPoint, we need to go buy the adapter. It's that simple. So then we heal wounds. Okay, this one. Okay, this is another botas patient. Everybody loves botas. If you are wearing boots and you have this wound, guess what? You're not going to heal, right? You need to, this is not even an offloading shooting. This is a don't walk on the thing. Get off the thing and don't walk on it at all. This man was still working at the rancho with botas, walking on the botas. I don't know what I'm healing. The doctor's not doing a good job. Like, you're wearing boots. Ese es un paciente con botas que caminaba con el pie así y con la bota también. Okay, no, pero ya se sanó, gracias a Dios. Sí hizo caso. It's also delivery. You tell a man what to do, he's not gonna like it. I am man. If you tell a strong lady what to do, I don't like it. I am Lopez. I'm gonna wear my botas till my foot falls off. So I told him, does it make logical sense to you that the botas are gonna squeeze the wound? Yes. Okay. So we want. This also you see the bone. You healed up. This was a non-funded patient. Next. And that's the patient I told you about. Next. And those are the references. And next. And that's the, okay. All right. So that's that. We're done with mine. Yay.
We got it open. Yeah.
He sees
Voy a cortarlo ahí.
and the